السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
وعليكم السلام ورحمة الله.
Walaikum assalam.
A very good morning, Dr. Hani.
Good morning, everyone. I will say good evening. Okay, guys, inshallah, today we will continue for teaching and practice. Regarding today resuscitation, we will talk about ALS, ABLS, ATLS, and of course, newborn resuscitation. Okay. Regarding the resuscitation, you have to check the scenario, the pie chart. I'm talking about the pie chart. The pie chart is talking about pure resuscitation or teaching resuscitation. Okay. So take care about this one. Okay. Here regarding pure resuscitation, it means you will follow the same approach of resuscitation. If you find the resuscitation in the pie chart and the teaching, it means you will follow the same approach of resuscitation, but you will follow also the general approach of teaching. Okay. So, for example, you will go inside the station, you will find one nurse. So you can say, I have been informed that you have one patient, whatever. If a child, you can say child. If adult, you can say adult. And also you can say trauma, if trauma. And can you tell me more about that? If teaching, she will say, or he will say, blah, 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 blah. Okay, so first of all, what about the patient now? Maybe they will say the patient was discharged yesterday, okay, or maybe the patient transferred to ICU, okay, but I want to learn how to deal with such patient, okay? So you will follow this general approach. For example, yeah, so first of all, we need to prepare our team. So for example, you will be responsible for airway and one nurse for circulation. And we have to wash our hands with PPE. And we should call adult resuscitation team or pediatric resuscitation team or trauma team. So I'm talking about the approach of teaching and resuscitation together. Okay, so be ready for anything. Okay, be ready for anything. So regarding pure resuscitation, it will be easy. You will go, you will find patient, whatever mannequin or not. Of course, it will be mannequin. Okay, or resuscitation will be mannequin. So I think all people here in this session, you have previous recordings, and I am sure all people you listen to previous recording. So no need to waste the time. Just I want to give you a clear idea. So we have 3 teams. Number 1, adult resuscitation team. Number 2, or I will say 4 teams. Okay. Number 1, adult resuscitation team, pediatric resuscitation team, and trauma team and neonatal team. Okay, for newborn. Here, you have 1 minute to prepare yourself. So you have to mention everything in preparation first. It's not logic. The patient have seizures and they called you, we will come after 1 or 2 minutes, and you did not inform your patients about seizures. Inform your patient about seizure, it means please prepare all medicines for status epilepticus or for seizures. Okay, so why the ambulances they are calling you? to prepare yourself. This is the difference between you and another candidate. All people, they will mention, are you happy to manage airway? Please prepare airway equipment. Done. All people, they will mention that. Are you happy to manage circulation? Please prepare all circulation equipment. Done. All people, they will mention that. But not all people, they will mention, we are expecting one patient with seizures, 5 years. Please prepare all equipment or all medicines for seizures. Okay. Patient pregnant. All people, they will mention, please prepare all airway equipment, circulation equipment, but not all patients. Sorry, not all candidates, they will mention, we are expecting patient pregnant. Please, once the patient come, we will put on left lateral side. So we will prepare cardiac wedge from now. Once the ambulance come, they will put the patient on cardiac wedge. So cardiac wedge here, guys, before airway or in circulation?
Circulation.
Before airway or in circulation?
Before airway, when the patient comes.
Before airway. Why we are
Before
preparing ourselves? Already you ask your team to prepare cardiac wedge. Already you put cardiac wedge on the table. Once the ambulance arrive, they will put the patient, the pregnant patient, on cardiac wedge. So cardiac wedge here before airway in preparation. Okay, this is the difference between you and the other candidates. Okay, why I will wait until the ambulance come? I will check airway, I will check breathing, I will check circulation. After that, I will remove the patient again and put cardiac wedge. It's not logic. Okay, so I want you to get high marks by this professionalism. Okay, so
Hello, Dr. Hani.
yeah.
Sorry, please. I didn't get what you were saying. You said we need to do what before patient comes? I didn't get that.
Okay, so here you have 1 minute preparation in the station. Okay.
Okay.
So here you have 1 minute preparation in front of the door. 1 minute preparation in front of the door. And inside the station, you have another 1 minute. Okay, you are doing that for yourself. You are doing that for yourself. Okay, so 1 minute preparation inside the station. Good morning, I am Dr. Digi. I am the AD consultant, or I am the most senior here. And may I know your name and the level, please? Or may I know your name and the grade, please? Or may I know your name and the role, please? All accepted. Blah, 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 blah. Nice to meet you. I need one nurse with me. The examiner will say, you can consider me a nurse. Ignore the examiner. After that, we are expecting one patient pregnant, 30 weeks gestation, RTA or ALS, you can, whatever the scenario, the same, whatever ALS or ATLS, the same approach, the same preparation. Okay.
Okay.
Yeah, because maybe ALS was bleeding, vaginal bleeding. Maybe ATLS was bleeding from any other area rather than vagina, plus maybe vaginal bleeding. So I don't care. I have to prepare myself. So are you happy to manage airway? How to save time? No need to say, can you please prepare airway equipment, oxygen, tubes, and no need. Okay, it's introduction. Whatever you will waste your time, it's introduction. The same marks. Okay, for introduction. So, can you please prepare airway equipment? Done. And you have only one nurse, but you can imagine another nurse with you. Just pretend another nurse in front of you. And you, are you happy to manage circulation? Can you please prepare circulation equipment? The patient is pregnant, so please prepare cardiac wedge and the put, and once the ambulance come, put the patient on cardiac wedge. Okay. Also, prepare O negative blood, activate massive transfusion protocol. Also, you will ask for PPE, wash our hands, wear PPE, and here call the team. The team will be according to the station. So maybe adult resuscitation team. Don't say code blue, code green, code. It's a local policy. I want you to talk by worldwide guidelines. Okay, so you can say call adult resuscitation team or call pediatric resuscitation team. Okay, or call neonatology team. If you feel the station with pregnancy and any possibility to deliver, so call a trauma team and ops and gynae and neonatology in the meanwhile. Okay, so here you are showing the examiner that you understand the station. You are showing the examiner that you are professional. Okay, be calm and also be fast. In resuscitation, you have to be very fast. If you will finish the station and you are slow, it's not good for resuscitation. All resuscitation should be fast, but in the meanwhile, be calm. Okay, and so on. We will see and we will give feedback. The most important in trauma, you will add manual inline stabilization and don't waste time. Okay, so just verbalize. I'm behind the patient. I'm doing manual inline stabilization. What about the airway? Or you can say to the examiner, is the patient talking? Okay, so if the patient talking, airway is patent. Done. If he said the patient is not talking or unconscious or, so you can ask about the airway. If he said the patient is not responding, so look, listen, and feel. Check the pulse. Okay. If he said there is pulse, what about the airway? I don't want you to waste the time. If you will say any secretions, you will say no. Any vomiting? No. Any lip swelling? No. Any foreign bodies? No. No. You are wasting time. One word. Is the airway patent? Yes. Done. I will go for breathing. Okay. But before going to breathing, you have to apply high flow oxygen. Except one case. What is that, guy? Except one case. What is that?
COPD.
Chest pain.
COPD.
Acute coronary syndrome. Acute coronary syndrome. COPD, you will give oxygen, but Venturi mask. You have to give oxygen, Venturi mask, 4 liters. Okay, 28%. Okay. So, if the patient acute coronary syndrome, you can ask for oxygen saturation first. If he said 94, you can verbalize to the examiner because maybe he will think you don't understand. His oxygen saturation for acute coronary syndrome accepted. No need to give oxygen now. Please give oxygen if oxygen saturation less than 94. Done, but don't apply. This is the only case. So in trauma, what is the difference? You will add NC in circulation. You will add abdomen. Inspection palpation. Inspection palpation. So what about inspection for abdomen? What about palpation? Any tender? So inspection here. Any bruises, any wounds, any injury? Done. Don't ask about anything else. I don't care about scars. Okay? It's not ALS station. So in palpation, any tenderness, rigidity, guarding, done. After that, the pelvis. Okay, is the pelvis stable? Yes or no? Okay. After that, any positive finding in abdomen or circulation, you will go for fast. You will go for pelvis X-ray. Okay, but you have to prepare in chest. So in chest, what about oxygen saturation? What about RR? What about inspection, palpation, percussion, auscultation? But you have to prepare first, connect to all monitors, expose the chest, connect to all monitors. After that, prepare chest X-ray and pelvis X-ray. Prepare, don't use, just prepare to be ready. Okay, to be ready where if you need in hemothorax or pneumothorax or hemothorax, you will need fast if there is positive finding. So if the patient has penetrating, no need for fast. This one penetrating and hypotension, go directly for OR. Okay. So here in C, in trauma, after pelvis, you will go for long bones, means arms and legs. Okay. Any deformity? Any injuries? No. So now you finish C. After that, everything is the same as ALS or ALS. Okay. What is the difference in pediatric? In pediatric, you have to verbalize with flag in the introduction. Guys, I am not teaching in details because already you have the recordings. Okay. I'm just giving a refreshment for our knowledge because this will help us today. Okay. So pediatric, number one, with flag, don't forget, just verbalize with flag, whatever the station is teaching or pure resuscitation. So just verbalize W for weight, E energy, T tubes, F fluids, L lorazepam, and A. So verbalize all quickly. Okay. After that, of course, you will find, once you will verbalize with flag, you will find in front of you in the station. If you don't find, no need. Don't waste the time. Okay. Just mention to the team, can we calculate with flag? Blah, 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 blah. Even if you will mention, we need to calculate with flag, done. But if you find, verbalize them quickly. Okay. What is the difference between adult and pediatric doses? Okay. And here regarding newborn resuscitation. Newborn resuscitation, I will comment after someone will do the station. I will not comment now. Okay. Okay. So here, guys, number one, 1 minute preparation before the station. So check the pie chart from down to up. Number two, the task. Number three, the scenario. In the scenario, ask yourself, this is station, resuscitation, ALS or ABLS or ATLS or newborn. After that, prepare yourself. I will go inside. I will waste 30 to 40 seconds. I don't want you to waste 1 minute. 1 minute too much in preparation. I will waste 30 to 40 seconds in preparation. Introduce myself, confirm their ID and level. I will tell them about the station. I will tell them about the preparation. I will give them tasks. I will ask them to prepare PPE and wash their hands. I will call for the team. After that, I will proceed from the airway. Airway, you have to be behind the airway. Whatever ALS, ABLS, ATLS, or newborn, you have to be behind the head. Okay. Chest, you have to be beside the right side of the chest. You will be on the right side on the chest. Okay. And B, except one case, except one patient, which is, guys, which is
Pregnant patient.
pregnant
Pregnant
patient.
patient.
pregnant patient, okay? Because you will be on the left side of the chest, because you want to do left lateral position. And if you will do CPR, you have to be in the left side. So if you are in the exam, prepare yourself for that. You are managing the airway, go behind the airway. If you will go for breathing, be beside the chest on the right side, except one station, pregnancy, whatever, ALS or ATLS. After that, you will go in the left side, okay? Of course, on Cardiff wedge. Even in Cardiff wedge, just emphasize on that. You can verbalize to the examiner, to your team. Always involve your team. You will get marks for involving the team. Now the patient on left lateral position, okay? So in C, you will be beside C, beside abdomen, on the right side of abdomen, except one station, pregnancy. After that, pelvis, you will be on the right side of pelvis, okay? Except one station, pregnant. After that, long bones, I'm talking about trauma. Long bones, you will be on the right side of long bones. Whatever arms, you will go again to arms on the right side of arms. After that, go back to legs. I want you to move actively. Show the examiner that you are moving, okay? If you are doing auscultation, even you don't have a stethoscope. In my exam, I don't have a stethoscope, but I'm pretending that I have a stethoscope, okay? It's not mandatory to take a stethoscope with you. It's not mandatory to take anything with you, okay? But I mean, you can pretend that you are checking auscultation and bend your body to auscultate, okay? Be active. Show the examiner that you are active, that you are moving from the head to the chest, moving to the abdomen, moving to the legs, from arms to legs, okay? So this is attitude. They are giving you marks not only for your approach, okay? Talk to your team. If you don't remember anything, so you can ask your team. It will give you marks, okay? Even, for example, the patient has methadone. What is the dose, guys, for methadone? Pediatric? What is the dose, guys?
0.01 milligram per kg.
So if you don't remember, you can ask the nurse, can you give naloxone according to his weight flag? Please check the algorithm, okay, and give, okay? So here they are not testing your knowledge. They are testing your skills. If you forget something, and what will you do? They are testing that. So even you will say, please confirm the dose of naloxone, check the algorithm, and give according to his weight flag. Done, okay? But I don't like. Always be ready for doses for everything. I don't like if you will do that. But at least if you don't remember, no worries. Okay, we will start. We have 15 doctors today to practice. Dr. Tariq, Dr. Meliti, Dr. Fayo, Dr. Ahmed Al-Amin, Abdullah Malik, and Aziz, Abdul Rab, Raji, Amjad, Omar, Abdul Latif, Omar, and Muhammad Al-Karim, Nasser, Ibat. I don't know who is Ibat. Okay, and Dr. Saadi. Okay, 16. Okay, we will start by H1. Dr. Tariq. Dr. Tariq.
Yes, yes, sir. I'm
Really?
reading.
We don't want to waste the time because today it's a very long station. So,
Okay.
yeah.
I will start.
La, you have 30 seconds, 30
Okay.
seconds to prepare yourself, okay? And be concise in introduction.
Okay.
You can start.
Okay. I will wash my hand and wear PPE. Good morning. I am Dr. Tariq, one of the senior doctor, and today is a team leader. May I know your name and level, please?
Yeah, I am Nadia. I am junior doctor.
Nice to meet you, Nadia. Can you arrange for another sister for staff?
Yeah, I am the examiner. You can consider me an nurse.
Okay. We receive a call from ambulance that we are getting a 4-year-old boy. He's coming. He's coming on the way, and he's drowsy and his BP is low. So we have to prepare ourselves. So, may sister staff, can you prepare for airway? Are you ready for airway?
Yeah, sure.
Okay, please prepare airway trolley. And what about you? Can you handle circulation?
Yeah, sure.
IV fluid and IV cannulas. Is it okay?
Okay.
Okay. Patient arrive. And please, before patient arrive, can you arrange for the pediatric resuscitation team and activate them? Is it okay?
Okay.
Patient arrive.
Yeah.
I will see the baby. Hello, baby. Baby is responding.
Baby is not responding to verbal. He's responding to pain.
Okay. I will go and I will check the airway. I will head tilt and chin lift. Airway. I will see inside. There is any secretion or any foreign body or any swelling.
I cannot open the mouth. The patient is seizing now.
Okay. So, sister, please, can you start high flow oxygen and please nasopharyngeal airway size and put inside and then start. Is it okay? Now airway is patent.
Not patent.
Okay, nasopharyngeal airway applied and high flow oxygen.
Airway is not
airway
patent.
patent?
No.
Airway is not patent. Okay, and please, before can you do the suction from the nasal as well as?
Suction done.
What about now, airway?
Patent now.
Okay, and I'm happy now for the airway, and we will go for, please continue oxygen 15 liter, and I will go for the breathing. I will check from the brachial. I will check the trachea is central.
Trachea central.
And please, sister, can you attach all the monitors and with the continuous monitoring of the blood pressure as well? Monitor attached?
Yeah.
Okay, and I will see if there is a bruise on the chest.
No trauma, doctor.
Okay, just rash. Okay. So I will see. I will auscultate the chest now. Neck veins. How about the neck veins?
Normal.
Okay, now I will auscultate. On auscultation, what about 6 points?
Normal air entry.
Normal air entry. Okay, that's good. Now I will percuss all the 6 areas.
Doctor, patient is seizing.
Okay, sister. Patient is seizing. Please, can you give him Valium, diazepam, according to the wet flag per rectal? Given.
Okay.
So now I will see that if there is airways, chest expansion is normal.
Yeah, normal.
Okay, please repeat volume after 10 minutes, 15 minutes, and let me know. Okay, what about now?
How long, doctor?
It's 15 minutes, 10 minutes. Actually, after 10 minutes, you have to repeat that. Is it okay?
Okay.
And now, what about the seizure now? Is still patient seizing?
Yeah, still seizing.
Okay, now we'll go for the circulation. And what about the saturation?
Saturation now is 98.
98, that's good. And what about the blood pressure of the patient?
Now it's 70/30.
Okay, sister, please can you insert the IV cannula to large bore IV cannula and please start the fluid 20 ml per kg according to the wet flag. Is it okay?
Okay.
Okay, now I will see. What about the extremities are cold?
Yeah.
Or warm? I will go for the CRT 1, 2, 3, 4, 5. What about the CRT?
CRT now it's 7.
7. Okay. So fluid is going on. So I will see the patient again. We will go for ABC. How about airway saturation is fine?
Saturation,
Airway is patent.
airway is patent.
Saturation is fine. Blood pressure.
Saturation is 98 and the blood pressure now it's 100/60.
Okay, now I'm satisfied from, yes. What about the seizure now? Still seizing patient because 5 minutes, 10 minutes passed.
10 minutes passed. Still
Child
seizing.
is seizing.
Yeah.
Okay, please, can you give another dose? Per rectal. IV fluid is there, so you have to give lorazepam 0.1 milligram per kg IV.
Okay.
So please, and I will go for the D. What about the blood sugar of the child?
Blood sugar now is 5.
Blood sugar is 5. Okay. And extremities?
Now extremities is cold.
Cold. And what about any lateralizing signs?
No signs of lateralization.
And I will check the pupil.
The
Pupil have
patient is
raised too much.
seizing. I cannot assess.
Okay. Okay. So still lorazepam is given and we have to wait. So I think so. Can you call the anesthetist? And the patient we have to secure the airway. Please.
The anesthetist is busy now.
Okay, we will try. We will prepare for the intubation.
Thank you, Dr. Tariq. Thank you. Time done. Okay. What do you think, Dr. Tariq?
I was little slow, but I think so. I can complete little bit, but it was any for long time I didn't do it.
Okay, no worries. Okay, so here this patient is seizing. Okay.
Yeah.
Okay, so here regarding the station. Okay, I said seizing. You did not start the clock, right?
Yeah.
Okay.
Yes.
So here your preparation is missing. You did not wash your hands. You did not wear PPE, right?
No, I did this. We wash our hand and wear PPE.
Okay.
Okay, okay, no problem. I will. Okay.
You can write this
Yeah.
comment. Okay.
Yeah.
Okay.
Yeah.
So you did not hand over the patient from the ambulance crew.
Yeah.
I need to hand over before approaching the patient. It's not logic. You will assess the patient and leave the patient and go to tech history. But it's logic. Now you did not receive the patient yet. So no worries. You can hand over from the ambulance crew. They will tell you blah, 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 blah. Okay. So after approaching the patient, I said from the start, can you please prepare airway equipment and you circulation equipment? Done. I did like that in my exam and I took high score. Okay. So I want you to do like that also. Just enough. Airway equipment, circulation equipment, done. Okay. The most important here, don't mention details of airway equipment and ignore handover from the ambulance. Okay. So please emphasize on hand washing, PPE, call the team early, and also the ambulance crew handover. Okay, very, very important. What do you need here from this station? Seizures. Okay, so the most important, start the clock, and also you will get access. Did you ask the ambulance crew any access done for the patient? You have to ask. Okay, maybe he will say yes, intraosseous access in the left leg. It will save time for you, right?
Yeah.
You are wasting 3 or 5 seconds in handover, but you will save minutes in the station. Okay, so here in airway, you waste the time, the patient is seizing, and here you can expect airway is closed, spasm. And here you have to do nasopharyngeal airway, after that suction, after that ask before high flow oxygen. Don't apply high flow oxygen and ask about patency. No, ask about patency before high flow oxygen. So high flow
Okay.
oxygen, the last step before going to breathing. Okay. And here,
Yes.
yeah, and here you will go for first step to give the patient medicine for seizure. Did you ask when the seizure started? No. Okay. So maybe the seizure started 1 minute. So 1 minute here, you will start the medicine after 4 minutes. Okay. So if they said the seizure started 5 minutes ago, so you will start now medicine. If they said the seizures started 10 minutes ago, you will start now. So more than 5 minutes equal than more than 10 minutes equal more than 15 minutes. Okay. So from 0 to 5, A, B, C, D, E, including blood sugar, from 0 to 5. 0 to 5, it means 0 from attendance ER, or if the ambulance crew started the medicine. Okay. So blood sugar here, it will be in D, disability, from 0 to 5 minutes. Okay. Anyway, well done, Dr. Tariq. You did not reach because you are not concising your approach. Okay.
Yeah,
Yeah.
I understand.
Yeah. You did not expose the chest. Okay.
Mhm.
And here you are going from B to C and then B. No, I want you to finish B. After that, go to C. Here in B, expose the chest, connect all monitors. What about RR? What about oxygen saturation? Always start breathing by RR, oxygen saturation. I told you guys before, if you will ask about oxygen saturation, it will give you clear idea about B, breathing. If the examiner told you oxygen saturation 98, the breathing will be okay or not?
Okay.
Yes, yes. Okay.
Why I will wait for 1 minute to ask about breathing assessment, and in the end of breathing, I will ask, what about oxygen saturation? It will give me idea clearly. Okay, so in breathing, start about oxygen saturation. Number 2, RR. Number 3, trachea. Number 4, neck veins. After that, inspection, palpation, percussion, auscultation. Here, once he will say oxygen saturation normal, I am sure, inshallah, inspection, palpation, percussion, auscultation will be normal. Okay? And here, no trauma in the scenario. So just ask about rashes and scars. ABLS, rashes and scars. Okay.
Yeah.
If they mention
Okay.
trauma in the scenario, pediatric and trauma, so you can say any rashes, any scars, any injuries, and so on. But anyway, no worries. But I'm caring about time. Okay. If you go to C, same as breathing. In breathing, which parameter we started?
RR and oxygen.
Oxygen saturation and the RR. In circulation, start by blood pressure and CRT. Especially in pediatric. Why? Sometimes you are not familiar with the blood pressure according to the age. But once he will say CRT is 7, this hypotension or not?
Yes.
Clear, right?
Yeah.
Okay. Will you give treatment before assessing the patient? Will you give IV fluid before asking for CRT? No. So what about blood pressure? What about CRT? I don't care about extremities cold or. It will waste the time. Okay. In trauma, okay, no worries. But here, just enough. Blood pressure, CRT. After that, give high flow oxygen. Give IV fluid according to weight flag. It will be 10 ml per kilogram. The new guidelines. Okay.
10.
After that, you will go for everything. Okay. I want someone to do this station, but I will.
Honey,
Yeah.
one thing. We give first dose and we give second dose. Still seizing now. We have to intubate?
Okay. First of all, you have to be familiar with the algorithm. From 0 to
Yeah.
5, A, B, C, D. D it involve blood sugar. Here, don't check blood sugar before airway. The first killing is airway, hypoxia. The causes
Yes.
of seizures, number 1, hypoxia. Number 2, hypoxia. So hypoxia because of airway. Number 2, hypoxia because of B, breathing. Number 3, shock can cause also seizures. Number 4, D, disability, like blood sugar, okay? Also like head injury. So D here, it means blood sugar and head injury, okay? So which one will kill first, blood sugar or hypoxia?
Hypoxia.
So treat hypoxia first. Even the examiner told you his oxygen saturation is 80 and the blood sugar is 1. Which one you will treat first?
Hypoxia.
Hypoxia, okay? So all cause seizure. So from 0 to 5, you will assess A, B, C, D. Don't jump to check blood sugar. It's not logic to jump to blood sugar now, okay? And no one will die from hypoglycemia. Be sure of that. No one will die from hypoglycemia. Okay, so after that, 0 and the 5 minutes started, give first dose of lorazepam according to weight flag. After 10 minutes, second dose of lorazepam. Here you have to ask the ambulance crew any history of epilepsy, 3 points in seizures in handover, 3 points. Any history of epilepsy, number 1. If yes, he is taking any medicine, maybe he's taking valproate or phenytoin. So you will change, okay? After that, he has allergy. Maybe he has allergy from phenytoin, so you will give phenobarbital, okay? So here you will ask the nurse. Don't waste for response. Don't wait for her to say 10 minutes passed. Maybe she will forget. Okay, you are the team leader. Ask the one is recording the time. 10 minutes passed. You are alert. You are the most of the team alert. Okay, so guys, 5 minutes passed. Still seizing. So give the second line. Guys, 10 minutes passed. Guys, 20 minutes passed. And before that, you have to notify them. Please, if 5 minutes passed, tell me. If 10 minutes passed, tell me. If 20 minutes passed, tell me. And from the start, the patient has airway compromised. Which specialist you will call?
Anesthetist.
So call the specialty early. Yes, you call for resuscitation, pediatric resuscitation team early from the start. But once you find any abnormality, call the specialty early. So the airway is compromised from the start. Please call the anesthetist because we are expecting this patient may need intubation at any time. Okay? Okay. Thank you, Dr. Tariq.
Okay.
Next one, Dr. Militi.
Just one question.
Yeah, sure.
Doctor, if the patient came and he is seizing an ambulance, they mentioned they give him 1 dose lorazepam.
Start from the end.
So I will not count 5 minutes.
Start from the end.
So I will give another dose. I will ask when the last dose given. Then I will give
Yes.
another dose. Then I
Yes.
will assist
So,
airway.
for example, if the ambulance crew said we did not give anything, thank you. When the seizure started, okay.
They
But
said
if
7 minutes. So I
yeah,
will give
7 minutes, it means for you 5 minutes.
Yeah.
10 minutes,
Then
it
I
means
will
for you
assess
5
airway.
minutes.
Okay.
If he did not give anything, but if he give any treatment, maybe he give first dose and maybe he give second dose. So you will start from his end. You ask him the second dose. When did you give? Clear?
Clear.
For example,
Yes,
he said 3 minutes back. So ask the nurse, please start the clock and after 7 minutes, tell me.
Okay.
You have to be alert, guys. You said you are the team leader. You are the most senior here. You should be careful for silly points. Okay? Don't
Okay.
let them to tell you. For example, in resuscitation, don't wait for the examiner to tell you 2 minutes past. Don't wait for the nurse to tell you 2 minutes past. You are the one asked. Okay? So you give medicine. You consider for H40s. Ask them 2 minutes past. She will say yes. Now you are saving the time and you are showing the examiner that you are professional. Okay? Okay, I want someone to do this station, but I will change the station. Dr. Milliti.
Yes, I'm ready, Dr. Hani.
Yeah, you have 30 seconds.
Okay, can we go back to the scenario?
Okay.
Okay, good morning. My name is Dr. Hassam. I'm the AD registrar for today. May I know your name and level, please?
Yeah, I am Nadia. I'm junior nurse.
Hi, how are you, Nadia? Are you an APLS trained?
Yeah,
Okay, I need one other nurse with me.
okay.
Okay, so Nadia, we're receiving a 4-year-old boy by the ambulance. He is drowsy and his blood pressure is 85 or 50. I don't have any more information. I want you to get ready. I want you to handle the airway, and that means deals with all the airway equipment. And the other nurse, I want you to handle the circulation and deals with all the appropriate equipment. I want you also to wear your PPEs and activate the pediatric resource team and calculate the wet flag, please.
Patient arrived.
Okay, so I'll approach the patient. I will check if the patient is responsive. Hi, baby. Hello.
The patient is not responding.
Okay, so I will approach the patient. I'll check if he is breathing and if there's any pulse.
There is signs of life.
Okay, so there's sign of us. I will check if the airway is. Now, before that, is there any endorsement from the EMS?
Yeah, this patient, he was collapsed at home. He lost weight and
Okay.
he was collapsed today at home. Yeah.
Okay, so is the
We
so the
inserted
patient-
we inserted IV access.
And there's an IV access. Okay.
Yeah.
So I'll go back to the patient now. I'll check if the airway is intact. So the patient is not responsive still. He's not doing any sound.
You find signs of life.
Okay, but is the airway intact?
The airway is patent.
Okay, so I will apply a high flow oxygen and I will check if the patient is breathing. Is there any saturation? I want to connect this patient to the monitor, one of the nurses, please, and check if there's any saturation. And what's the saturation and respiratory rate?
Saturation now is 94 and the RR is 45.
Okay, so I think he's slightly tachypnic. I want to do a quick examination. Neck, is the trachea centralized?
Trachea is central.
No neck congestion?
Neck vein normal.
Okay, I will do inspection of the chest. I will expose the chest and the neck. Chest movement, okay, bilateral?
Yeah.
No wounds, no scars. Okay, I will palpate the chest for any tenderness or chest expansion, and I will.
Expansion normal, bilateral.
Percussion.
Percussion normal.
Auscultation.
Resonant to
8
all.
points. Okay, so I would like
Normal
to do an X-ray for this patient, and I would like to move to the circulation part since the breathing is okay. So is there a blood pressure cuff connected? Can you tell me what's the blood pressure and the pulse rate?
Blood pressure now is 80/40.
And the pulse rate?
The pulse rate, this one, the monitor.
Okay, okay. So I have a normal pulse rate. Nadia, can you check if his blood pressure is normal as per his age? Capillary refill time?
Now is 7.
Okay, so that's prolonged. I think that this patient is in shock. I want to insert into a large IV for cannula.
There is one cannula, doctor, by ambulance crew.
Okay, so we'll use this cannula to give an IV fluid according to the wet flag, 10 ml per kilo. And please arrange to insert another IV cannula for him as well. Can you check if the blood pressure and the capillary refill time improved now?
Still the same.
Okay, so I'll continue giving fluid for the patient and check if there's any signs of bleeding. Any signs of bleeding from any artery?
No trauma, doctor.
Okay, so there's no trauma. Okay, so can you do an abdominal examination, see if there's any tenderness, blooding?
No.
No. Okay, so I'll continue give an IV fluid until the patient's circulation maintained.
Blood pressure now is normal.
Okay, so that's good. Circulation is okay now. I'm gonna move to the disability part. I want to check the GCS ACPU of the patient. Is he alert now?
The patient now is unresponding.
He is not responding at all. Okay, I'm gonna check if there's any signs of life. Is he breathing? Is there any pulse?
Yeah, signs of life. Yeah.
Okay, so if the patient is not responding, okay, so can you check the RPS, please?
RPS now is 16
Is that normal for it?
millimole.
Okay, is this normal or not? Not sure.
16
Okay.
millimole. The normal is 4 up to 8.
Okay, so the RBS is okay. Can you check the pupils, please, and check if there's any signs of lateralization?
Yeah, there is unequal pupil and dilated on the right side.
Okay, all right. So I would like to go next for the exposure. I will do a full examination from head to toe to this patient, and I will check the temperature as well. And I think that maybe this
Temperature
patient has a history.
temperature 37 and no
The
rashes.
temperature. Okay, so I would like to inform the pediatrician and the pediatric ICU as well to be involved with us.
Thank you. Thank you.
Thank you.
Okay. Here, your time management, Dr. Hussein. You are doing well. You are amazing. Okay. Here, you connect the monitor without exposing the chest. Is it logic?
No, it's not logic.
Okay. So first of all, you finished airway, connect high flow oxygen, expose the chest, connect all monitors, oxygen saturation, RR, inspection, palpation, percussion, auscultation. Done.
Mm-hmm.
After that, circulation. Why you are wasting time? Blood pressure, CRT, give fluid. Here, give fluid without extracting blood. Is it logic?
No, I need to extract blood, at least for
Yeah.
blood group across matching.
You have to remember the ambulance crew, they have one IV access. Excellent. Okay, so you can tell them, insert another IV access. You show the examiner that you are very alert. You are really professional. You are really the team leader. Okay, insert another IV access. Okay, in the other arm, and extract the blood, hematology, biochemistry, blood gas, blood culture, blood toxicology screen. Okay, remember that and fix that in all stations, even trauma. Extract the blood, hematology, biochemistry, blood gas, blood culture, toxicology screen, and give fluid 10 ml per kilogram according to his weight flat. Warm. Fix that. Okay, warm. In any resuscitation, especially in trauma. Okay, you did very well. You went to D. So the patient has blood sugar. Don't ask the examiner, is it high or low? You have only 2 reading for blood sugar. Milligram per DL, the normal from 80 up to 120, right?
Mm.
If millimole,
That's
it will be 4 to 8. If hypoglycemia, if the station is hypoglycemia, it will be something obvious, like 1, like 1.5, like 2. If hyperglycemia, it will be something obvious, like 13, 14, 15, 16, and so on. Clear? Okay.
Clear.
So I like when you said the patient tachypneic, but talk to the team. Guys, the patient is tachypneic. Guys, insert another. Guys, the patient maybe it's a DKA. Okay. So the patient has unequal pupils. What does it mean?
Increase intracranial pressure.
Excellent. I want another word, guys. What does it mean?
Coning of the brain.
Cerebral
Herniation.
edema. Cerebral edema. We are talking about DKA. Mentioned by name. Cerebral edema. The patient has maybe cerebral edema. Okay. So please, here already you extracted blood gases, right?
Yes.
You said hematology, biochemistry, blood gases, blood culture, and toxicology screen. Any result? So why you are extracting blood? Just routine? No. To check the results. If you did not ask about the results, you are not professional. Okay. So once you ask about the results, they will show you the ABG. What do you expect, Dr. Hussam, in the ABG?
Metabolic acidosis.
What else? High anion gap. Okay.
Ion gap. Yeah.
HAGMA. Okay. It will not be clear for you, HAGMA, but at least just verbalize. Once they will show you the ABG, which parameter you will check? Two parameters. Number one,
pH.
Bicarb.
pH. Number two, bicarb. Excellent. So you can say pH 6.9 and the bicarb is 14. The patient has metabolic acidosis. If you find less than 5, so severe metabolic acidosis. If you find pH less than 7.1, severe metabolic acidosis. Okay, this patient needs admission directly. Okay, so call pediatrician team. Okay, and start. What is the management for this patient?
Fluid and insulin.
IV fluid.
Normal saline first, and if suspected of
DKA protocol,
edema, cerebral edema, we are giving hypertonic saline.
Don't say we are giving. What is the guideline say? Okay.
The
Don't say
guideline
we are giving. Okay.
hypertonic saline for
If the
CT,
patient,
CT and
yeah,
CT first to exclude the
CT, it's a secondary survey,
edema,
please,
cerebral
doctor.
edema.
CT, it's a secondary survey. Now we are in primary survey. Okay. Okay. So let us to finish the primary survey. Primary survey, we are talking about resuscitation fluid. Okay.
Yeah.
After we finish A, B, C, D, E, and after that, we will reassess A, B, C, D, E, and start the secondary survey. So the secondary survey, after stabilization of the patient, we can go for deficit fluid. After that, maintenance fluid. They are not testing your knowledge. Just if you stabilize the patient, just verbalize to the examiner, I will continue deficit fluid. I will continue maintenance fluid. Done. Thank you. I will treat. Maybe after giving mannitol or hypertonic saline, the patient will improve. Maybe you don't need later for CT. If the patient is not responding, you can consider CT. Okay, so here, if the patient, you need to give mannitol or you need to give hypertonic saline. If the patient is hypotensive, which one is suitable?
Hypertonic.
So in this station, you will give hypertonic saline or mannitol?
Hypertonic.
Hypertonic saline, because he is hypotensive. Okay, so you verbalize to the examiner, the patient has signs of cerebral edema because of DKA, so is hypotensive. I have two options, mannitol. Talk to your guys. Guys, we have two options, mannitol and hypertonic saline. But because he is hypotension, please give hypertonic saline. Whatever, 3% or 2.7 or whatever. Okay. Okay. So is it clear, Dr. Hussam?
Yes, Dr. Hani, it's clear. Just one thing to Dr. Hani, I see that your advice is to go fast and everything. In the real exam, when I do any part, A, B, C, like, am I like actually doing it in the patient or just verbalizing it? For example, like doing auscultation,
verbalizing only and acting. So here, can you see the mouse? Now I am in airway. I will be here. Okay. Now I am in breathing. I will be here. In circulation, I will be here, besides the abdomen and the pelvis. okay? And I am exposing the chest. When I say expose the chest, I will hold the chest and pretending that I am the one exposing. Did you get my point?
Yes.
Just show the examiner that you are helping yourself quickly, okay? So once you will ask about trachea, put your 2 fingers here. Once you ask about veins, hold the neck veins. Did you get my point?
Yes, Dr. Hani.
Yeah, this marks for you, easy marks for you, okay? So after that, everything will be verbalization, okay?
Okay.
Yeah, next one, Dr. Fayo.
Hello, doctor.
Yeah. You have 30 seconds. You can start.
Hello, good afternoon. I'm Dr. Pugh, one of the senior doctors. May I know your name and level, please?
Yeah, I'm Nadia. I am junior doctor.
Nadia, nice to meet you. We've been informed that 4-year-old boy will be brought in by ambulance. Are you APLS trained?
Yeah,
Are you happy to manage the airway?
sure.
Okay, please prepare all the necessary equipments and also call for the another APLS trainers and let her do the circulation and prepare all the necessary medications and equipments.
Okay.
Okay, also alert the pediatric resuscitation teams. Okay, and let's wash our hands and wear PPE. Okay, is the patient arrived? Okay, any endorsement from the ambulance team?
Yeah, this patient, he was collapsed at home and no trauma, and he has seizures. Seizures started 10 minutes ago. We inserted IO access in the left leg, and
Okay.
we give first dose of lorazepam 0.1 ml. Yeah, according to
Okay, did he have any epilepsy or taken any medications?
Yeah, he's taking medication phenytoin.
Okay, Nadia, please calculate the word flux for the baby, and I'm gonna check the airway. Is the patient airway patent?
The patient
Still seizing?
is seizing, yeah.
Okay, so Nadia, please insert the nasopharyngeal airway and also call the anesthetist team. The time may have to airway compromise at any time. And how about the airway?
The airway now is not patent.
Okay, not patent.
Yeah.
Okay, we need to do the intubation and also we need to set the clot for the seizure and also already given the 10. So we
Why
need to
you
give
want to
an
do intubation, doctor? I am examining.
examiner. So
Yeah,
the patient is season and not patent. Yeah. So we need to prepare for the intubation. Call the anesthetist team, but not now.
You are not competent in intubation, and the anesthetist is away now. He will come after 10 minutes.
Okay, so we're gonna give the oxygen for now, and he needs another dose of the lorazepam right now immediately. 0.1
Not yet.
milligram per kg.
How long between the first and second dose?
10 minutes apart.
Not yet finished, doctor.
Oh, okay. So prepare for the intubations, wait for the anesthetist team, and alert me when 10 minutes are finished. And we're gonna move to the breathing and gonna remove the expose the baby and put on the monitors and also check the respiratory rates and saturation. How is that? Hello?
Okay.
So what about the saturation?
Saturation 98.
Respiratory rate?
Respiratory rate is 45.
45 tachypnics. Okay. And is the trachea midline?
Yeah,
And what about the neck veins?
normal.
Normal. And how about the inspection of the chest? Any deformity?
Normal.
Any? Okay. And palpation?
Normal.
Chest wall expansion. Okay.
Normal.
And percussion and auscultations?
Resonant and normal air entry.
Normal air entry. Heart sounds?
Normal.
Guys, is 10 minutes passed or not?
Again?
10 minutes passed or not?
Yeah, 10 minutes passed.
Is the patient still seizing?
Still seizing.
Okay, give the another dose of IV lorazepam 0.1
Give
milligram
him.
per kg. Okay, so I'm gonna check the circulation. And how about the blood pressure?
80/40.
80/40 and pulse rate? Pulse rate? CRT? Sorry, hello?
Okay. Yeah, CRT now is 3.
3. Okay, so I like to give the 10 ml per kg IV fluids with according to the work bloods, and also insert the another IV cannula on the other side and draw bloods and send for the hematology, biochemistry, toxicology streams and black cultures and black gases. And please alert me after 10 minutes past of the lorazepam dose. Okay.
Yeah, finish the doctor, and the patient is still seizing.
Okay, guys, the patient is already on the phenytoin, so we need to give the phenobarbital 20 microgram per kg.
For how
according to
long,
the
the
work
doctor?
blast, for 20 minutes.
Okay, 20
And
minutes.
alert me after that.
Stopped now.
Alert me.
Stopped. The seizing stopped after 20 minutes.
Okay, so I'm gonna check the airway. Is the airway patent?
Patent.
Okay, and how about the saturation?
98.
98, good. And how about this blood pressure?
120/80.
120/80. Okay, how about the disability? Any signs of lateralization?
Normal.
Pupil?
Normal.
Pupil normal. Blood sugar?
5 millimole.
5 millimoles. And temperature?
Thank you, Dr. Fayo. I will give you 1 minute. 1 minute. Okay, continue.
And how about the temperature?
I want you
Temperature
to
of
be
the baby?
fast. Be fast.
Okay. Okay. And expose the baby any skin rashes or anything of
No
that?
rashes.
Okay, I'd like to call the pediatric team for the ICU admission.
Okay, they are coming now.
Okay, is he arrived?
They are coming now.
Coming now. Okay, so sorry.
Continue.
Continue.
Reassess the patient.
Okay, as the airway stay patent.
Patent.
Okay, any breathing as
Be
saturation?
fast. Be fast. Oxygen saturation.
Saturation?
98.
98. And the blood pressure?
120/80.
Any pupil equal or not?
Equal.
Pupil? How
You
about the
asked me
conscious
about
level?
this. You asked me about this before, right?
Yeah,
Okay.
and how about the ABPU score?
The patient now is responding to pain. So what is the differential diagnosis, doctor? I'm the examiner.
I think the epilepsy, status epilepticus.
Okay, what
So it
are the
means-
differential diagnosis? It means
the
what are the
infection-
other causes?
Infection of the brain, also the meningococcus septicemia.
So you mean infection or sepsis?
Yeah, infection, sepsis.
Sepsis, whatever the cause. Okay. What
And
else?
Electrolytes imbalances.
Electrolyte imbalance. Okay, what else?
4H40s. I mean the hypoxia. No, yeah, hypoxia.
The patient
Yes,
doesn't
yes.
have hypoxia. Okay. What else?
Yeah, and toxins.
Toxins. Excellent. What else?
Mm,
Head injury?
yeah, but they said no injury. or no.
Whatever, but we are talking about differential diagnosis. If the examiner asks you
Okay.
about differential diagnosis, you have to mention to the examiner head injury, one of the differential, but there is no trauma.
Okay.
Did you get my point?
Okay, got it.
Yeah. Here, one of the differential sepsis, you ask the examiner, what about the results? What about blood gases? Clear?
Clear.
Yeah, this station, it was in my exam, and he asked me everything. I finished everything. I called for pediatric team. He said on way. I reassessed the patient. Everything was normal. I asked him about all results. He said all results are normal. He asked me what about the differential diagnosis. So you have to mention the differential diagnosis, but tell him this one is likely, this one is unlikely, and so on. Okay?
Oh, okay. Yeah.
You can say also in this age, maybe febrile convulsion, but the patient has history of epilepsy. It's unlikely. Did you get my point?
Got it. Yeah.
Yeah. So you have to show the examiner how you are thinking, how you are rolling in and rolling out. Did you get my point?
Yeah.
I wish you do that without asking without a question from the examiner. I want you to do that with your team. So guys, let us to think about differential diagnosis. The examiner is instructed to ask you in case you don't do that. But if you do that, this is the difference between you and the others. Clear?
Yeah, I see.
Okay.
Clear.
I wish. Okay.
Thanks.
Thank you. Next one, Dr. Ahmed Al-Amin.
Yes, Dr. Hani.
Yeah. Guys, we still in 2 station. Okay. You have 30 seconds, Dr. Ahmed. You can start.
Good day. I'm Dr. Ahmed Al-Amin. I'm going to be the team leader for today. I'm ED registrar. May I confirm your name and your level, please?
Yeah, I'm Nadia. I'm junior nurse.
Nice to meet you, Nadia. Are you ALS certified?
Yeah.
Excellent. We need another nurse who is ALS certified, as I received a call about the arrival of a patient who is 70 years old. Already is in the emergency department. I need you, Miss Nadia, to handle his airway, prepare all airway equipment. Are you happy to do so?
Yeah.
Okay, and for the other nurse, I need her to prepare the circulation equipment.
Okay.
Are you happy to do so?
Yeah.
Okay, excellent. Let us all wash our hands, put on our PPE, and call the adult resuscitation team to join us as soon as possible. The patient is here, I think, in the emergency department, right?
Patient arrived.
Okay. Okay. Is there any handover from the ambulance?
Yeah, this patient was collapsed at home, 70 years. She's drowsy. She is talking but drowsy, and we inserted IV access in the left hand and another IV access in the right hand.
I was told that she is having an overdose. Do you have any idea about the medicine she took?
I did not check, doctor.
Okay, thank you very much. I'm going to approach the patient. Hello, ma'am. Are you all right? Any response? Okay, the patient looks to be confused. Is the airway patent?
The patient is talking, patent.
Okay, please, Ms. Nadia, apply a high flow oxygen 15 liters by non-breathing mask. I'm going to proceed for the breathing. Please expose the chest, connect all monitoring. What about the trachea and neck veins?
Normal.
Okay, what about the oxygen saturation respiratory rate?
94, RR is 40.
Okay, the patient is slightly tachypneic. Okay, let's proceed. Check the chest. What about by inspection? Is there any abnormal breathing pattern?
Normal.
By palpation, chest expansion?
Normal.
Percussion 6 points and auscultation 6 points. Okay, auscultation of the apex, any
normal air entry?
Murmurs? Apex auscultation?
Normal.
Okay, I'm happy with the breathing. I'm going to move forward the circulation. Please connect the patient to monitor.
Doctor, I'm the junior nurse. I found this tablet in his pocket, something like amitriptyline.
Yes, this tricyclic antidepressant. It can affect the brain, causing seizures, and can affect the heart and causing arrhythmias. So, okay, let us proceed for continuing the assessment of the patient. Okay, what about the blood pressure and the pulse of the patient?
Yeah, blood pressure now is 70/40.
Okay, so the patient is shocked. What about the capillary refill?
7.
Okay, so what about the extremities, temperature and color?
Cold.
Okay, we have already 2 IV lines. I need to start infusion 1 liter of normal saline in one of them. From the other, draw blood for blood, hematology, biochemistry, blood culture, blood gases, toxicology screening. We need to contact the tox space for this patient. She will need an antidote. For now, do we have an ECG for the patient?
What is this ECG, doctor?
This is the effect of the amitriptyline on the heart. It will cause cardiac arrhythmia. There is widening of the QRS complex, prolongation QT interval and PR interval. Okay, I need to give this patient now 100 milli. Do we have the result for the blood gases?
Yeah, the blood gases now metabolic acidosis.
Okay, give 100 ml of sodium bicarb 8.3 infusion. Okay, and we are going to continue our assessment for the patient. What about the pupils of the patient? Okay, ma'am, are you all right?
The patient is unconscious now.
Look, listen, and feel. What about the pulse?
There is pulse.
Okay, excellent. So what about the blood pressure?
Same.
Okay, so the patient is showing, I need another dose of 100 ml sodium bicarb for her. And please prepare for infusion for this patient of the ECG showing you wide complex tachycardia. It is ventricular tachycardia. What about the blood pressure for her?
Same.
Okay, can we please call the cardiologist immediately? This patient is having unstable ventricular tachycardia, and also call the anesthetist. Now I'm going to proceed for the cardioverting of the patient. Please attach the defibrillator and put it on 120 millijoule synchronized. Okay, everyone's clear. I'm clear. Oxygen away. Now, shock delivered. Any change in the monitor?
Yeah, this is the same.
Okay, check the pulse, please, and the blood pressure.
There is pulse and the blood pressure is still the same.
Okay, give another shock, please. 140 joules synchronized. All clear. Shock delivered. What about what is the change in the rhythm?
This is the monitor.
Okay, is there a pulse?
Yeah, pulse.
Blood pressure?
Same.
Okay, give another shock, please. 150 joules synchronized.
Given.
Okay, monitor VTAC still. What about the pulse? Any pulse?
There is pulse.
Okay, blood pressure?
Same.
Okay, we need to start antiarrhythmic. We'll give lidocaine 1.5 milligram per kilogram intravenously.
Okay, given.
Okay, any change in the monitor?
Yeah, now
okay, check the pulse.
now the patient is sinus rhythm.
Okay, check the pulse, please.
There is pulse.
Okay, what about
Thank
the blood
you, Dr.
pressure?
Ahmed. I will give you 30
Dr.
seconds.
Okay, what about the blood pressure of the patient?
100/60.
Okay, excellent. Let's call the ICU team. We need to them to receive this patient, and I'll go for a reassessment of the patient. What about the airway?
Beaten.
Okay, what about the oxygen saturation?
98.
Okay, blood pressure?
100/60.
Okay, pupils?
Equal bilateral active.
Okay, any signs of lateralization? Random
No
blood
signs.
sugar and Glasgow coma score?
Blood sugar
okay,
is 5.
Exposure of the patient? Any
What do you
rashes
need?
in the body? Blood
No rashes.
temperature? Blood? No rashes. Temperature of the
37.
patient? Okay, ICU arrived?
ICU arrived.
Yes. Hello, sir. I'm Dr. Ahmed Amin, ED registrar. Are you the ICU doctor on call?
Yeah.
Yes, we received this lady. She was coming with an overdose, tricyclic antidepressant. While assessing her, she showed wide complex tachycardia. Initially, we had given her 100 millimole of sodium bicarb. The patient went into unstable ventricular tachycardia. We cardioverted her 3 times. We give her lidocaine infusion. The patient is now stable. She needs admission for further management in the ICU.
Did you give intralipid?
No. We haven't given intralipid yet.
Okay. So what is your recommendation?
My recommendation: admission to the ICU, giving her intralipid, continuous cardiac monitoring, and
thank you.
Consultation of toxobase. Thank you.
Okay. Thank you. Okay, well done,
Thank
Dr.
you.
Ahmed. Here you are very fast, and you did not finish within 6 minutes. Okay, so you have to concise your approach. If you are very fast and you did not reach, it means you have to concise your approach. So here in airway, already you have to verbalize the patient is talking, even drowsy. The patient is talking. When I asked the examiner, is the patient talking? He said drowsy. I said, what about the airway? He said the patient is talking. I told them, okay, so the airway is better. So it's better from the start to save time and tell him the patient is talking, the airway is better. Okay, apply.
Because I was not clear about this, Dr. Hani, because we usually, when an assessment is if the patient talking normally, we know that the airway is
I
normal.
agree with you.
But
I
if
agree
talking
with you.
abnormally,
And
sometimes
yeah,
this is why I confused about this one.
no worries, no worries. For the purpose of the exam, the examiners, they are considering that. So we have to save time according to them. Okay, I agree with you. Sometimes the patient is drowsy, but the airway is not patent, or sometimes the patient has anaphylaxis, okay, and they're talking and he has a stridor. So it's not patent. I agree with you. But for the purpose of the exam, just talk to him like that. Okay, the patient is talking, the airway is patent. Apply high for oxygen and proceed for breathing. Okay, so you did very well. Here, if you see the ECG, just one word, ECG showing TCA toxicity, done. Don't explain the ECG, it's not teaching you. Okay. After that, the ABG showing metabolic acidosis. Now you have indication to start sodium bicarb. Okay, the patient is collapsed, so you have to start sodium bicarb, also fluids. Okay, and if you want to give magnesium sulfate, also no worries. If you want to give intralipid, the patient collapse or arrest, it's indication to give intralipid. Okay, after that, the patient is not responding, you have to give synchronized decision. But I like if you tell the examiner, in the meanwhile, prepare for this shock. Okay, so start sodium bicarb, start fluids, and turn on the defibrillator for synchronized tissue shock. Okay, so now you are in pharmacological cardioversion and also electrical cardioversion. Excellent. They will give you, the patient is not responding for 3 times, so they will test your skills. They will give amiodarone or you will give lidocaine. So amiodarone here, contraindicated. If the patient went in seizures, what is the medicine here, Dr. Ahmed?
Midazolam. Lorazepam. Benzodiazepines, I mean. Lorazepam or midazolam.
Which is contraindicated in this station?
Phenytoin.
Okay. Thank you, guys. Thank you.
Dr. Hani, just a question. If, for example, in a resuscitation, you are stuck in the airway or the breathing or the circulation, the examiner wants something and you can't reach what is in his mind. What is the correct here? Is to like bypass it and continue and lose the mark in this part, or to keep standing in this area, or how to deal with that?
You can save time. You can save time. For example, you are in C circulation and the blood pressure is still low. So already you give, for example, fluids, okay? And you ask him, the blood pressure is still low. You give blood and the blood pressure is still low. You give O negative blood. So after that, you give cross match 4 units, still low. So here he doesn't want you to jump to D, okay? So it means something urgent here in this system, okay? But here, for example, in airway, you have only some possibilities. Like Dr. Fayo, she jumped to intubation. What is the indication to intubate the patient in seizures? Okay, you have to follow the algorithm. Number 1, you will give first dose. Number 2, second dose. Number 3, phenobarbital. If the patient is not responding, you can go for rapid sequence induction. Clear, guys? I'm talking about the seizure station. But if the patient from the start cannot maintain airway, cannot maintain breathing, what does it mean? Airway is not patent. Breathing oxygen saturation is 80, despite high flow oxygen, despite nasopharyngeal airway, despite suction. Okay, so what is the next action?
Back valve mask, ventilation, then intubation.
You give back valve mask and the patient on high flow oxygen and the oxygen saturation is 80. What is the next action?
Intubation.
Intubation, rapid sequence induction. If the patient is seizing and you give only one dose, or you did not give any dose at all, and the patient not maintaining airway or not maintaining breathing, you have to jump, you have to pass to a rapid sequence induction. Okay. Otherwise, you will go step by step.
My point, Dr. Hani, if you are for any reason, for example, something you forget, something you get a mental block in this area, you can't reach what the examiner wants, like for example, in the chest. Like I heard before, there was a patient with fractures in the ribs, maybe flail chest, and the examiner saying you cannot do percussion. And many, they were stuck in this. If you cannot reach what the examiner wants, what is the correct decision? To keep on trying in the same area, or to like try to bypass it and say I will come back or whatever? How is to deal with this one? What will give mark or will be the least loss for you?
Excellent. What is the target in this area? So A, B, C, D, A. What is the target in A? Airway patent or not, right?
Yes.
Don't proceed to breathing until you listen from the examiner airways patent. This must, okay? But in breathing, what is the target in breathing? Oxygen saturation more than 94. Don't bypass to C until you find 94. In circulation,
if you bypass, you lose the whole station, or you will lose the part of the breathing in the station.
No. Don't worry. Okay, but here in circulation, if the blood pressure is 90/60, 90/60, and you give, for example, fluid, no problem. If you will say to the examiner, the fluid is running now. In the meanwhile, I will continue assessment of the patient. No worries. Did you get my point?
Yes.
Because you don't want to say, to waste the time. And does this happen in practice? Do you think if you will give the patient fluid, his blood pressure, he will increase in quickly? No. Okay. So, but here fluid for how long? Fluid challenge?
15.
15 minutes. 15 minutes. Fluid challenge, 15 minutes. What does it mean, fluid challenge? You will give 250 up to 500 ml on 15 or 10 to 15 minutes. So the primary survey, 5 to 7 minutes. Okay. All primary survey, airway, breathing, circulation, disability, and exhaustion. So it's not a big issue, doctor. Okay.
Okay.
Yeah. Next one, Dr. Abdullah Malik.
Yes, doctor.
Alaikum salam. You have 30 seconds?
Yes, okay. Okay, I will start.
Okay.
Good morning, I'm Dr. Abdullah Malik, one of the AD registrar. I'm the team leader today. May I know your name and level, please?
Yeah, I am Dr. Fathi. I am AD registrar.
Okay. Are you ATLS provider?
Yeah, sure.
Okay, and can you manage airway? Please prepare a difficult airway trolley. And are you the other nurse?
Yeah,
are you also ATLS provider?
Yeah.
Okay, so please prepare all the resuscitation drugs and IV cannula, and because we are going to receive a 65-year-old male with RTA and his blood pressure is low, so please activate massive transfusion protocol and also activate adult trauma team, and we will all wash our hands and wear PPE. Any endorsement from the ambulance crew?
Yeah, this patient was in RTA and he has contusions in head, chest, and abdomen as well.
Okay. Any past medical disease or any IV cannula or any medication given?
Yeah, we inserted IP access both limbs, upper limbs.
Okay. So I will approach the patient. I will go to the head end of the bed and do manual inline stabilization. Hello, sir. Hello, how are you? I'm Dr. Abdullah.
Patient
Is
is
there
not
any response?
responding. Not responding.
Okay, I will look, listen, and feel for the pulse and breathing. Is there any
There is
pulse?
pulse. There is pulse.
Okay. I will open the airway with the jaw thrust, and also, is the airway patent?
Patent.
Okay. So I will nurse C. Are you familiar with putting C collar?
Yeah.
Okay. So I will do the manual inline stabilization, and you can release the sizing and putting the C collar. Is the airway still patent?
Patent.
Okay. So now please connect to high flow oxygen with non-rebreather mask. And also please alert the anesthetist. This patient might need intubation. Now I'm happy with the airway. I will go to breathing, expose the chest, connect all monitors. What about the trachea and neck veins?
The trachea is central, neck veins normal.
Okay. And what about respiratory rate and oxygen saturation?
Oxygen saturation 98. Respiratory rate is 40.
Okay. I want to ask for chest X-ray, pelvis X-ray, and fast scan because this patient is hypertensive and history of RTA. I will do inspection. What about the chest rise? Any scar marks, any deformities?
Normal.
Okay, for on palpation, what about the chest expansion,
Normal.
bilateral, equal? Okay, on auscultation, 6 points.
Normal air entry.
And percussion, 6 points.
Resonant.
Resonant also. Okay, and heart sounds on the
Normal.
apex. I will auscultate. Okay, this one I have done from the right side, and I'm happy with the breathing. And now I will go to see circulation. We have connected the monitor. What about the blood pressure
100/60.
and pulse?
Pulse now is 140.
Okay. What about the CRT and
CRT 3.
Okay. So I will take 2 large ball IV cannulas, and also there is one line from the ambulance group. So, and take bloods for hematology, biochemistry, blood gases, and also will connect to the IV fluids because this patient was in shock. So, and after that, I want to come to the abdomen. What about the abdomen and inspection? Any signs of scar marks or any deformity or any?
No injuries, normal.
Okay. On palpation, any guarding, any tenderness, any rigidity?
Normal.
Okay. And I will do now the file. No. Okay. And I will check for the pelvis. Is the pelvis stable?
Stable.
Okay. I will check for blood on my gloves. Any blood on the floor and 5 more?
No.
Okay. So now I will reassess airway. Is the airway patent?
Patent.
Yes. And what about saturation?
98.
And blood pressure?
100/60.
Okay. And I have circulation. Any long bones? Any injuries? Any injuries on the limbs? Any extremities?
4 limbs normal.
Any obvious bleeding?
4
Okay.
limbs normal.
So yes, 4 limbs normal. So I will go to disability and check for any pupils and bilateral equal
Pupils
reactive.
unequal pupils. Right side dilated.
Right side dilated, and any signs of lateralization?
Yeah, there's signs of lateralization.
Okay. And what about the blood sugar?
Blood sugar 5 millimole.
Blood sugar 5, and there is signs of and pupils dilated on the right side.
Yeah.
Okay. Okay. So I will check for. I will expose the limbs, and any chest X-ray and pelvis X-ray is normal.
Normal.
Okay. And come to the exposure. We will expose the body. What about the temperature?
37.
Okay. And any other injuries? We will do log roll. We will call more to staff for do the log rolling and check for the back. Any injuries on the back?
No.
Okay. So this patient most likely because of the radiated pupil and has a history of RTA and most likely had injury and increased intracranial pressure. And I want to continue with the controlled ventilation and give hypertonic saline and mannitol. And I would want to refer the patient urgently to neurosurgery and ICU team. They arrived.
Yeah, ICU team here and the neurosurgery is here.
Okay. Good evening. I'm Dr. Abdullah Malik, one of the registrar. We received this patient from ambulance by history of RTA, and he was hypotensive, and airway was patent, and breathing circulation was compromised.
Thank
We
you.
give IV fluids. And
Thank you.
yes.
Thank
Okay. Thank you.
Okay. What do you think, Dr. Abdul?
Well, I was expecting something like maybe flail chest, have massive hemothorax, but everything was going normal. So I was not expecting going everything only until D, disability, pupils are is unequal. So I
Okay.
just diagnosed that it could be.
Did you talk to your
Yeah.
team? Did you involve your team?
I involved. I assigned the roles, yeah, but later on I did not involve them much.
You are only one man show. Okay, it's not good. Okay.
Yeah, yeah, I
Doing
understand.
very
Yes,
well.
this is not.
You are
good.
doing very well. You are fast, and also
Yes.
you are organized. Everything is amazing, but I wish if you involve your team. Okay.
Yes, exactly. Yeah, yeah.
Yeah, guys, we have already 2 axes. So please extract blood, hematology, biochemistry, blood culture, and toxicology screen. Even trauma, yeah, even trauma. And here, do you need to give fluid? The patient blood pressure is normal. Do you need to give fluid here?
Yeah, 1 liter bolus still we will give.
Yeah, do you need? The patient is
Yes,
normal.
we need to give.
No need. No need.
Okay.
If the patient is stable, no need. Because
in this, I was considering in the scenario, and then later you said 100/60, so I thought maybe compensated.
yeah,
better.
if the ambulance crew they called you, they said, for example, we have one patient 85/50. Maybe now blood pressure is normal, right? Maybe they started the fluid, maybe anything. Okay, so maybe blood pressure is deteriorated. Maybe his blood pressure not readable now, right?
Yes, yes.
Don't depend on the parameter on the scenario, because the ambulance crew they call you, they will arrive after 2 minutes. Within 2 minutes, many things can happen. Maybe he will arrest. Okay.
Yes.
Okay. So don't depend on that. Anyway, regarding, we were in this one. Sorry. Yeah, this one. Okay. So here, once you go for the disability, patient has signs of lateralization, unequal pupil. So you can say most likely he has head trauma, and maybe it's cerebral edema, right? Sorry, cerebral bleeding. Okay.
Cerebral intracranial hypertension.
Yeah. Be sure in the exam everything will be clear. Not like that. They will mention in the scenario the patient had head injury. Clear?
Yes.
But I did not mention here to test your skills. Okay?
Yes. Yes.
For sure, they will mention in the scenario the patient has chest injury. So you will understand the problem in chest. They will mention in the scenario the patient has pelvic injury. So you will understand the problem in the pelvic. Clear, guys?
Yes.
Don't worry. Okay? The patient is drowsy and he has overdose. It's clear. You will understand maybe TCA, maybe beta blocker, maybe calcium channel blocker. It's the most common exams. Okay? Most common station. It's not secrets. They are not testing your knowledge. They are testing your skills, how to deal with this situation. Okay? So, excellent. I wish if you finish ABCDE, I will hand over the patient to ICU team, including neurosurgeon. Okay?
Yes. Yes.
He will say, if the examiner said he is here now, so you can hand over. If he said on way, so you can verbalize, I will reassess the patient. Clear, Dr. Abdullah?
Yes.
So if he did not mention the neurosurgeon is here or ICU team are here, so it's accounted for you. But you did not mention, okay? You did not mention to me. So it's not counted. Clear?
Yes.
So at any time, any station, LS, ABLS, ATLS, or newborn, after you finish the stabilization of the patient, I want to hand over the patient to blah, blah, blah. In the meanwhile, I will reassess the patient. Okay, I wish it's clear. Yeah.
Yes.
Okay, Dr. Aziz.
Yes, Doctor.
How are you?
Thank you. You.
Okay, so we have two Aziz here.
Yes, I am Aziz Vatan.
You are from Turkey, I think.
Yes, Turkey.
Yeah, okay, now I know. Okay, so this station, you have 30 seconds.
Okay. Okay, I can start.
Okay.
Hello, I'm Dr. Aziz. I am the ED senior. May I confirm your name and level, please?
Yeah, I am Dr. Fathi. I am ED registrar.
Great, nice to meet you, Dr. Fatih. Now we have a patient, 8 months old boy. So we need someone else. Are you happy with the airway?
Yeah, yeah.
So please prepare the airway equipment. And you are ALS provider, right?
Yeah, yeah.
Oh, okay, great. So the nurse, please prepare for the circulation and circulation equipment.
Okay.
Now, is to the ED ambulance? Is the patient at the ED now? Okay. Now, is the patient? Does patient give reaction in the ED, right?
Yeah.
Okay. I will approach the patient by look, listen, and feel. Is there reaction?
The patient is not responding.
Not responding. Okay, I will check the airway firstly. Is airway patent?
The patient is not responding.
Not responding. Is there a pulse?
You find the signs of life.
I found. Okay then. Now I will check the airway. Is airway patent?
Airway is patent.
Patent. Great. Now I will expose the chest and check at the same time check for RR and saturation.
Yeah, the saturation now is 80 and RR is 7.
7, saturation 8. Okay, then I will start high flow oxygen, 15 liters. And by the way, listen the chest. Is chest sounds bilateral echo?
Yeah.
Yeah, great. How is the saturation now? I gave oxygen.
Saturation now is 85.
85. Okay. Now, does the patient responsive? Is there positive? Well, now I will monitor I will do the monitorization of the patient and check for the BP and pulse and CRT. Are they normal?
Okay. The CRT now is 8 and the blood pressure now is 70/20.
Now let's open two large ball cannula and take the blood hematology, biochemistry, blood culture, and blood gases. Now I will check the blood sugar.
Blood sugar now is 5.
5, okay. And check the pupil. Is there equal and reactive?
Yeah, equal and reactive.
And what is the AVPU score?
Now is responding to pain.
Responding to pain. Okay, I think AVPU is low. Is there a suspicion of toxicology? Is there any history of toxic drug or anything else? I don't think so. Now I will check for the temperature. Is it okay?
37.
37, great. And check for the rashes or anything else.
No rashes.
No rashes. Great. I will reassess the patient. Now I gave oxygen. Is airway patent still?
The airway is patent, yeah.
Yeah, okay. Now how is the saturation? Saturation was low and respiratory rate was low.
Yeah, saturation is now 80 on high
Mhm.
flow oxygen, and RR now is 5.
RR is 5. There can be two things, team, there can be two things, maybe opioid toxicity or something else. In this patient, we can give naloxone according to wet flag. Is there any improvement?
No.
No, by that time we can intubate the patient.
You are not competent in intubation.
Okay, then we let's call the anesthetist team and pediatric
Okay, the
resuscitation team.
anesthetist came and intubate the patient.
Intubate the patient. Now let's check what's the observations, saturation and blood pressure.
Saturation now is 70.
70, and it's going down and down. I will check the breathing sounds again. Are there echo?
There is no chest rise.
No chest rise. So I will check the intubation tube if there is a blockage.
Thank you. Thank you.
Mm-hmm.
Well done, Dr. Aziz. Okay.
Thank you.
Okay. You are thinking by logic way, but deep thinking. This station or resuscitation or OSCE, they don't want to think deep. Okay, they are not testing your knowledge. Just to follow steps. Okay, Dr. Aziz.
Okay.
So
okay.
Here you don't give yourself competences. The examiner, he is the one responsible for giving competences. Clear? So if the examiner tell you you are competent, you are competent. You are not competent, you are not competent. Okay? So you are competent in practice, in real life. For intubation, it's another issue. But in the exam, the examiner, he is the one giving you a competency. Okay? The examiner, he is the one telling you the anesthetist is available or not, cardiologist available or not, or whatever. Okay. Here, if the patient is not responding, so I will check signs of life. No need to say pulse. Okay. In pediatric, I will check signs of life. Signs of life, it means breathing and circulation. Clear, Dr. Aziz?
Yes, yes.
Yeah. First of all, go behind the patient. If you want to go behind the patient, okay. If you want to verbalize to the examiner, I will be behind the patient. So tell him any signs of life. But here I want you to be beside his breathing and check, listen to his breathing sounds and check his chest rise. Did you get my point?
Yes, yes.
This is how to get marks. So in the meanwhile, ask the examiner, any signs of life? He will say yes. It means he has central pulse or not. This is the meaning in pediatric, okay? The next step, you can ask him from the start. Before that, you can ask him what his AFBO score. He will say whatever. First action, what is AFBO score? So he will say responding, not responding, responding to pain, to verbal. The patient is alert. You have to use that in pediatric. After that, any signs of life. After that, what about airway? Don't waste the time. What about airway? Is the airway patent? Yes, patent. Done. High flow oxygen. After that, breathing, expose the chest. What about oxygen saturation? RR. Inspection, palpation, percussion, auscultation. Don't jump to auscultation, Dr. Aziz. Number one, inspection. Number two,
Inspection.
percussion, auscultation. Okay. Anyway, this patient, he has a low respiratory rate, right?
Yes.
What is the differential diagnosis here?
I thought the opioid intoxication.
Excellent. Excellent. Do you have history in the scenario that the patient has overdose?
I forgot to ask the ambulance team.
Yes. In introduction, you did not call for pediatric resuscitation team. You did not wash your hands and wear PPE, right?
Yes.
Yeah. And you did not take handover from the ambulance crew. Okay. But here in breathing, RR is low. What is the normal RR, guys, in general?
10.
12 to 20, right? In adult. In pediatric, it will be different. Okay. So
30.
Yeah. So this patient, what are the differential diagnosis? You said maybe toxicity. Okay.
Or head injury, intracranial trauma.
Head injury. Okay. Excellent. What else?
Status asthmaticus.
Maybe asthma. Okay. What else? Maybe the patient has ALTI, right?
Yeah.
Globiness. Okay. So here, inspection normal, palpation normal, auscultation normal. If auscultation normal, is it asthma?
No.
No.
His age, 8 months, asthma?
8 months. No.
It's not more than 2 years, so unlikely to be asthma. So less than 1 year, what is the most likely diagnosis? ALTI. Okay. This is how to prepare yourself, guys. You have 1 minute preparation inside outside the room. Once you see any pediatric 8 months, think about to diagnose. What is them? What they are, guys?
Bronchiolitis and ALTI.
Excellent. This, I want you to be professional. I want you to be intelligent. They will give you the most common stations. So think about ALTI, think about asthma, think about
bronchiolitis.
But 8 months, you have only 2 differential diagnoses. Bronchiolitis and ALTI. Okay. How to differentiate? Chest clear.
Chest.
Airway patent. In bronchiolitis, the airway will be patent?
No, secretions will be there.
Excellent. Secretion will be there. So you will clear oral or nasal?
Nasal.
Both.
Nasal. Okay.
Nasal.
Oral, even there is secretion in mouth, it's not a big issue. But anyway, for the purpose of the exam, just verbalize clear secretion. Done. Okay. It's not a big issue if you will say oral or not. If you will say clear secretion, clear airway from secretion, done. Do suction, done. Okay. So here the patient RR is low, so you have to go for airway again. Okay. This patient on high flow oxygen and the oxygen saturation is not good. So you have to remove non-rebreather mask and exchange with back valve mask.
Back valve mask.
Will you use back valve mask without airway adjuncts? No back valve mask. Remember that in practice or in the exam. No back valve mask without airway adjuncts. Okay. So here you will use oropharyngeal airway or nasopharyngeal airway?
Nasopharyngeal.
We don't know. We don't know. So try oropharyngeal airway. Ask the examiner, is the patient tolerating oropharyngeal airway? How to save time? You will ask the nurse, insert oropharyngeal airway, and then ask the examiner tolerating oropharyngeal airway, or you can ask the examiner directly, is the patient tolerating oropharyngeal airway? Which is saving time? Asking. The examiner. Yes. So you ask the examiner, high flow oxygen, what about breathing? The oxygen saturation is low. So you can say the patient has hypoxia on high flow oxygen. Is the patient tolerating oropharyngeal airway? If he said no, what does it mean no?
Go for
There is gag reflex.
If there is
and,
gag reflex, you will go for nasopharyngeal, right?
Exactly.
Exactly. So if he said yes, he is tolerating oropharyngeal airway.
It means loss of the protective reflexes. He may end up with the intubation.
It means the patient has no gag reflex. It means he has no airway reflexes. Okay. It means he needs intubation. Any patient needs oropharyngeal airway, go directly, call anesthetist, and this patient needs intubation. You are not competent. You are not competent. And the anesthetist is not here. So I will waste the time, Dr. Ahmed Al-Amin.
No, Dr. Hani, I'm going to start the bagging of the patient.
Yeah, back valve
in the
mask.
Airway
Back
and
valve
continue,
mask.
and continue my assessment. Yes.
Yeah, back valve mask. I am not competent in airway intubation, and the anesthetist is not here. So back valve mask, and I will wait for anesthetist. So here, back valve mask, it will increase the oxygen saturation.
Yes.
No.
Yes.
No, it will not increase. Back valve mask will not increase. Intubation will not increase oxygenation, but bagging will increase oxygen saturation, right?
Yes.
Why when Dr. Aziz, he said intubation done and oxygen saturation is low? Because he did not give order for bagging, right?
Okay.
The rate.
Okay.
The rate. So if you will use back valve mask, give rate for the nurse. Please give one ventilation every how much, guys?
5 seconds.
In pediatric, you can say 3 seconds. In pediatric, you can say 3 seconds. Clear, guys? Clear? So back valve mask will not increase oxygen saturation. Intubation will not increase oxygen saturation. But once you intubate the patient, connect it to back valve mask and give rate one ventilation every 3 seconds. Clear, Dr. Aziz?
Yes, yeah, Dr.
Yeah. So if give rate, ask the examiner or the nurse, what about oxygen saturation now? 95, done. So the tube is in. Also, what about ATCO2? So any intubation in any station in the exam, ask about 2 points. What about oxygen saturation? What about ATCO2? After that, you can proceed. If you feel the oxygen saturation is low, if you feel oxygen saturation and ATCO2 is abnormal after intubation, it means the tube it's in the right side. If the oxygen saturation is low but constant, what does it mean? The oxygen saturation is 80 after intubation, but it's still 80, not decreasing. So it's in the right main bronchus. If the oxygen saturation is decreasing, so 80, 70, 60, 50, 40, so it's out. It's not inside the trachea. Clear, guys? Okay. Well done, Dr. Aziz. I wish everything is clear. So here, once you will intubate the patient, once you will connect it to back valve mask, once you oxygen saturation will be okay. So what is the management plan here, Dr. Aziz?
I will call the pediatric ICU team.
Yeah,
and
so
hand over
once
the
you
patient.
finish E, I want to call pediatric team. In the meanwhile, I will reassess ABCDE. Okay, so this patient, high risk or low risk?
Very high risk.
High risk.
High risk. Okay, so the patient is collapse, and also the patient needs. So here they will give you any information in the scenario. It will be clear. So the patient is unwell. It means he is high risk. Okay, 8 months, high risk or low risk?
High.
Low risk. Low risk. If more
Below
than
1
2
month,
months, more than 2 months, it's a low risk. But unwell, it's a high risk. So if the patient in the exam you find no need for any intervention, so it's low risk and it's unlikely. But if in the patient unwell, so it's high risk. Okay. Anyway, this patient needs investigation, also needs admission because high risk. The guidelines, low risk, no need for investigation, no need for admission. Okay, Dr. Amjad.
Yes, hello, Dr.
Hello, Dr. Hani.
Yeah.
Sorry, please, one question. In this particular case, what is the diagnosis, this one?
ALTI.
Okay.
Okay, so you can verbalize to your team, to the examiner, guys, 8 months, or you can say less than 1 year. It's good to say less than 1 year. Don't say 8 months. Okay, less than 1 year and the patient unwell, so it's a high risk for ALTI. Here you are showing the examiner you are professional. Okay, yeah. Next one, Dr. Amjad.
Yes, hello, Dr. Hani.
Yeah, welcome. You have 30 seconds. You can start.
Okay, I need to wash my hands and wear PPE. Good morning, I'm Dr. Amjad, ED Registrar. May I know your name and level, please?
Yeah, I am Dr. Fathi. I am ED Registrar.
Nice to meet you. Are you ALS trained?
You mean ALS, doctor?
Sorry, are you ALS trained?
Yeah.
Okay, so we need someone else to help. Are you happy to deal with the airway?
Yeah, yeah.
Okay, and the other one will deal with the circulation.
Okay.
Yeah, guys, you all wear PPE and wash your hands, please. We are expecting a 70-year-old man with massive hematemesis. He's drowsy and he's hypotensive.
Okay.
Okay. Patient arrived.
Yeah.
Okay. I need to take handover from the EMS.
Yeah, the patient has liver disease history, past history, and he was collapsed at home. He vomited 3 times and with massive bleeding.
Okay.
We inserted IV access in both arms.
Okay, thank you. And I will check I will assess the patient. Is the patient responsive?
No, the patient is not responding.
Okay. Any sign of life? Any pulse?
Yeah, there is central pulse.
Okay. So I will assess the airway. Is the airway patent?
Airway is patent, yeah.
Okay.
Now the patient vomited again.
Okay. We need to call the ALS team and anesthesia. We will do suction for the vomiting, and we'll go for the breathing. We'll put nasopharyngeal airway and connect to oxygen. What about the SpO2?
The patient vomited again.
Okay, so we will put the patient in left lateral position to prevent aspiration, and we'll do suction. We'll can we put IV line, take blood, please, and give an antiemetic. Okay, I will continue with the assessment. I will check the airway is secure. We will put nasopharyngeal airway, and we will connect to oxygen. We'll check the breathing. What about the respiratory rate and SpO2?
RR now is 30 and the SpO2 is 90.
Okay. So
Patient vomited
we-
again.
Okay, we need to put an ET tube. Can we call the anesthetist?
You are competent.
Okay, so I'll proceed. I will put the ET tube and secure it, and connect to bag valve mask with with the ambu bag with oxygen. And what about the SpO2 now?
Okay, so what is the rate for back valve mask?
We'll give one breath every 5 to 6 seconds.
Okay, oxygen saturation now is 95.
Okay. Okay. So we'll continue with breathing. We will expose the chest and we'll check the trachea.
Trachea central?
Any scars or rashes?
No.
We'll percuss the 6 areas.
Normal, resonant.
Okay, we'll auscultate
Normal
the
air
sounds.
entry.
Okay, so we're happy with breathing. We go for circulation. What about the blood pressure?
Blood pressure now 80/40.
Okay, guys, have we secured the line, IV line?
Yeah.
Okay, so we'll give IV fluid. Please give 500 ml normal saline bolus. And what about the blood pressure now?
Blood pressure now is still 80/40.
Okay, we will give 1 liter saline bolus and we'll reassess the blood pressure.
Still 80/40.
Okay, we will give another bolus up to 40 ml per kg. Sorry, up to 4 times. We'll give 1 liter again of IV fluid bolus.
80/40.
Okay, we will tell to prepare cross match and save and prepare for massive blood transfusion. And what about
massive cross match is ready now.
Okay, so we'll give the blood.
How much?
We will give 1 pint now.
Thank you, Dr. Amjad.
Okay.
Thank you. Okay. What do you think?
I think I'm very slow and I did not.
Yeah, you are very slow. Number 1. Okay, you are amazing. You are approaching everything logically, but I want you to work on management of bleeding. So you have steps here. Whatever LS or ATLS, maximum 1 liter. Any bleeding, maximum 1 liter, because fluid will increase the bleeding. Okay, it will cause hemoperfusion and it will cause increase the blood pressure. It will increase bleeding. Anyway, so step number 1, fluids. Step number 2, O negative blood. Step number 3, you can write that. Step number 3, cross match 4 unit or 6 unit. Clear? And you have to call the specialty early. Which specialty here?
Gastro.
So you will call them after the patient arrive or before the patient arrive?
Yeah, before the patient. Yeah.
Because any hematemesis needs GI specialist, right?
Yes.
This patient at any time needs endoscopy. Okay, so patient is unstable, needs endoscopy for sure. Okay, so this patient, whatever, maybe he will not respond to fluid, terlipressin, tranexamic acid, also antibiotic. You will give everything, cross match, and he is still bleeding, right?
Yeah.
Can you do anything for him?
No, the gastro has to do ligation.
Endoscopy. Yeah. Okay. If endoscopy not available, what is the immediate action?
Second tube.
Ligation of bleeding vessels.
Balloon tamponade.
Balloon tamponade.
Indication of balloon tamponade if the patient is still not responding, okay, and endoscopy is not available, or at least not available now, okay? So you will go for single stick tube. Here you have to do intubation first before balloon tamponade, but already you intubated the patient. You took too much time, Dr. Amjad, in intubating this patient, right?
Yes.
If the patient is vomiting, do suction, done. What about airway? Baton, go for breathing. So high flow oxygen and go for breathing. A patient is vomiting again, this indicate intubation, clear?
It's clear now.
Okay. And he said from the start, the patient vomited 3 times. So at any time, he needs intubation. So you can call anesthetist. And guys, here I want you to be professional. So I said in 3 stations, I am ED registrar. May I know your name and grade? I said ED registrar. Something good for you or bad?
Bad.
Bad? Why bad?
Good.
If you have
Good,
consultant,
for
if you have
taking all of
consultant
those.
will support you in resuscitation room, good or bad?
Good.
Good.
Good. You show me that it's good. Oh, fantastic. I'm really happy. Right? This communication skills, guys, you have to show the examiner your expressions. Okay? So here, the most competent, give him the airway. So here, the ED registrar will be the airway. You are the most senior. Maybe you are senior registrar. Maybe you are a consultant. Okay? And he is ED registrar. So you are the most senior. Okay? So anyway, here, step by step, in intubation, I want you to ask the examiner, am I competent to intubate the patient? Ask him clearly, am I competent to intubate the patient? If he said no, is Dr. Fathi competent to intubate the patient? No. Is the anesthetist available? Clear, guys? This is how to communicate with the examiner, how to communicate with the team. Okay. You can ask the Dr. Fathi clearly. No need to ask the examiner. Dr. Fathi, are you competent to intubate? If he said yes, he's instructed to say yes. Clear, guys? Guys?
Yes, clear. Yes, clear.
Yes.
It's clear, look.
Okay. Okay. So I want you to be ready for everything. And here, after you finish stabilization of the patient, you can ask the examiner again, is the GI specialist or team, GI team available now? He will say, for example, yes or no. So I will continue the assessment of the patient. Okay. So Dr. Amjad, don't forget O negative blood, fluid, O negative blood, cross match, terlibricine, and also, please, if you have, guys, if you have children beside you, make mute your mic. So O negative blood, cross match, terlibricine, because it's very severe, antibiotic, and also tranexamic acid. Okay, high dose of BBI, it's okay. But the most important, terlibricine on negative blood and the cross match and the tranexamic acid. Okay. Next one, Dr. Abdul Latif.
Okay.
You have 30 seconds. You can start.
Good morning. My name is Dr. Abdul Latif Ali, ED Registrar. May I know your name and your level, please?
Yeah, I am Dr. Fathi. I'm ED Registrar.
Glad to find you in my team, Dr. Fathi, today. So,
Yeah.
Dr. Fathi, we expected a patient with RTA, and he's drowsy and hypertensive. and he needs resuscitation. He's 65 years old. So, Dr. Fathi, is it okay for you to care after the patient airway?
Yeah.
Okay, Dr. Fathi, we are going to call another nurse to care after the patient circulation.
Yeah.
So we need to call to activate the resuscitation team, trauma team, sorry, and also we need to activate the mass transfusion team, and we will wash our hand. We will wear our PPE, and okay. Any endorse from the ambulance?
Yeah, the patient has a chest injury. He was in RTA and he has crash injury.
Okay. Okay. I'm gonna first to do a manual stabilization. Manual stabilization to the patient head. Is a patient response?
The patient is unconscious but is responding.
Okay. So is the airway better?
Better.
Okay, I will give the patient high flow oxygen, 15 liters per minute, and also can you, Dr. Anwar, can you apply cervical collar?
Done.
Okay. Is the airway better after the cervical collar?
Done.
Okay, so I'm gonna attach the patient to the cardiac monitor and expose all expose the patient. So okay, now how about the trachea?
Central.
Any encouraged neck pain?
Normal.
Okay.
Sorry,
how about
the trachea is deviated to the right side and the neck vein are congested. Yeah.
Okay. Okay. How is the respiratory rate?
45.
SpO2?
80.
Okay. By inspection?
As you see.
Inspection.
As you see here.
Okay. Is there is a wound? Does the wound is sucking or?
No.
Okay. So I'm gonna do by palpation, chest expansion.
There is decreased expansion in the left side.
Okay. And percussion.
Percussion hyper resonant on the left side.
Okay. And auscultation.
Decreased air entry in the left side.
Okay. And okay. So what about heart percussion? Heart auscultation.
Normal breath, normal heart sounds.
So the patient most likely has pneumothorax, tension pneumothorax involved in his left side. So I'm going to prepare to insert wide bore cannula in the fifth intercostal space, just anterior to mid-axillary line. Okay. How about the patient now? I mean, how about the SpO2?
Same.
Okay, so I'm going to proceed to insert chest tube, and I will ask also for chest X-ray, pelvic X-ray, and EVAS. Okay, so our chest tube is inserted now.
Where?
In fifth intercostal space. At the same time, the same area where I try to do that for in the fifth intercostal space.
The wound is in the fifth intercostal space.
So I will do it in the fourth intercostal space.
Okay.
Yes, and I will connect it to underwater seal. Is there any bubble or?
Yeah, bubbles.
Okay, there's bubbles. So I will secure the airway and I will just clean the wound. I just cover the wound. So now, how about the oxygen saturation?
Now it's a 98.
Okay, now I proceed to see the circulation. How about the blood pressure?
Blood pressure is 80 over 50.
Capillary reveal?
7.
Okay, and pulse rate?
140.
Okay, I'm going to insert wide-bore cannula in both sides, and I will extract blood for hematology, biochemistry, blood gas, and cultural sensitivity, and also I'll give the patient 1 liter of normal saline, and also I will ask for preparing for O negative blood, and also I will give the patient tranexamic acid. So I proceed to assess the abdomen. How about the abdomen by inspection?
Normal.
Okay. What about how about the pelvic?
Stable.
Stable. Okay. So how about the long bone? Any?
Normal.
Okay. So then I will ask about the temperature.
Thank you, Dr. Abdullah. Okay, well done and amazing. You are going step by step by logic approach. Again, what is your problem here?
Because I want to call the
no. In general, I am always telling you what is your problem.
Yes, my tone is a bit
My tone,
slow.
your tone, yes. Okay, so you are doing well, Dr. Abdul Latif, but I am worried about your tone. You are slow. Okay, always doing well, but you are slow. Okay, so I want you to reach handover. I want you to reach reassessment. I want you to reach debriefing your team. Guys, what do you think? What about the differential diagnosis? What did we do well? What did we do bad? Okay, we want to evaluate ourselves and. Okay, so I want you to reach everything. If you reach everything by concise approach and by complete approach, you will get 10 out of 10. Clear, Dr. Abdul Latif?
It's okay. Yeah, clear.
Yeah, okay. But you are doing very well in airway, in breathing, in everything. You are doing very well. And here also in needle thoracocentesis, ask the examiner in case of air, he will say yes. So I will insert chest tube in the 5th intercostal space. Ask him, where is the wound? He will say, in front of you. Yes, where? Which intercostal space? Okay, you have to ask him. Even he said in front of you, you have to confirm with him. Okay, so if in the 5th intercostal space, no need to insert in the 5th intercostal. You can insert in the 4th intercostal space. Okay, and also connected to underwater seal, you did that. Ask him, any bubbles of air in underwater seal? Yes. Is it associated with blood? Clear, Dr. Abdul Latif?
Yeah.
Maybe pneumohemosis, right?
Yes.
Yeah. Is it associated with blood? No. Okay. So you can proceed. Here, regarding blood pressure is low, more than enough to give fluids. He will improve after fluid. But if he is not improving, you can proceed. Tranexamic acid or negative blood. After that, cross match step by step. Don't give everything together. Maybe he will improve with fluids. No need to give blood. Clear?
Yes.
Yeah. Did you call for the specialty early? Which specialty here do you need?
I need a cardiothoracic surgeon.
Did you call?
No.
No.
No, I have to call. Yeah.
So here, after assessment, call for the specialty. So what about oxygen saturation, RR, trachea, neck veins, inspection, palpation, percussion, auscultation? Yeah, the patient most likely he has, guys, involve your team. Most likely it's a tension pneumothorax. So the wound is not sucking, it's not open pneumothorax. So show the examiner that you understand. Okay, here you can call for cardiothoracic early. Okay, you can tell them at any time he needs intervention. Okay, so you can proceed. After that, you can confirm after you finish ABCDE. What about the cardiothoracic surgeon? available? No. So I will reassess the patient. Blah, blah, blah. So trauma team available and so on. Okay, well done, Dr. Abdullah. Next one.
Dr. Hani, one question here. If like this open wound on the chest, so we will put the 3-way sterile dressing first before the tube, or after the tube we will put the dressing?
Yeah, actually the examiner asked about what will you do with the wound. He asked all people regarding this point. What do you think?
Yes.
Question for more.
According to the wound.
Cardiothoracic surgeon will be suturing.
Is it suturing here, primary survey?
No, no.
No, we will put 3-way sterile dressing. There will be.
It's not open pneumothorax, right?
Yes.
Yes, it is not open.
Yeah, you will do 3-sided occlusive or 4-sided occlusive?
4-sided.
4-sided. 4-sided.
For me, I will put 3. I want to be in safe side. I will put 3. Any problem if I will put 3?
No, definitely not.
I will clean the wound. I will clean the wound and put 3-sided occlusive dressing. Done. Okay. Okay.
Okay.
So, yeah.
It can be totally occluded after the chest tube insertion, right?
Your voice is very far.
Yes, Dr. Hani. I'm saying it can be occluded from the foreside once the chest tube is inserted.
Yeah, if the chest tube is inside, it's okay. 4-side. But what is the problem if you will put 3-sided? No worries. Okay.
Okay, Dr. Hani.
Yeah. Next one. Dr. Omar, Muhammad Omar.
Yes, doctor.
Yeah. You have 30 seconds. You can start.
Yes, doctor. Good morning. My name is Dr. Muhammad Umar, immediate registrar. I'm the team leader today. May I know your name and level, please?
Yeah, I am Nadia, junior nurse.
And the other one?
Fadia, junior nurse.
Nice to meet both of you. Both of you are APLS provider?
Yeah.
Okay, Ms. Nadia, are you happy to take care of the airway?
Yeah, sure.
Can you prepare the all airway equipment and difficult airway trolley?
Yeah.
And Ms. Fadia, are you happy to take care of the circulation?
Okay.
Okay, kindly prepare the all resuscitation meds and IV cannulas and medications. Okay, we are expecting a 10-month-old child brought by the ambulance with a history of diarrhea vomiting. And we should wash our hands every PP, and we should call the pediatric resuscitation team. And let's get ready for that. Patient arrived. Any ambulance crew for endorsement?
Yeah, vomiting diarrhea, doctor, 3 days, and he was collapsed at home. I brought him here. He has IO access in the left leg.
Okay, thank you. I will assess the baby. Is the baby responsive?
Responding to pain.
Responding to pain. Okay, what about the airway? Airway is patent?
Not patent.
Not patent. Okay, I'll do a chin lift, open the airway and make suction. Is the airway patent?
Not patent.
Okay, we will insert the oropharyngeal airway. Is the patient tolerating?
He has vomiting.
He has vomiting. Okay, we will do the section and insert the nasopharyngeal airway. And how about the airway? And put the high flow to the airway is patent now?
Patent.
Okay, I'm happy with the airway. I will go to the B. I will exposed chest, connect all monitoring. And what about the trachea?
Central.
What neck veins?
Normal.
What about the RR?
40.
40. Saturation?
98.
And on inspection, any rashes or good chest rise?
Normal.
Palpation?
Normal.
And percussion on 6 points?
Normal ear entry.
And auscultation on 6 points?
Resonant.
Heart sounds?
Normal.
Normal. I'm happy with the breathing, and we'll go to the C. And we need to check what's the heart rate rhythm and 12 leads ECG. Okay, this is normal sinus rhythm. What about the blood pressure? Heart rate 77, and blood pressure.
Blood pressure.
Hyperacute T wave.
Blood pressure is 60/20.
Blood pressure 60/20. And CRT?
Yeah, CRT now it's 7.
7. Okay, we need to insert 2 large IV cannulas, extract blood for hematology, biochemistry, and blood cultures and blood gases tox screen. And we need to start the IV medications like IV fluid according to the wet fly, 10 ml per kg. And this one most likely in the ECG hyperacute T waves. And we can give
Patient is not responding.
Look, listen, feel. There is brachial pulse.
You mean signs of life?
Yeah, signs of life.
There is no signs of life.
No signs of life. Okay. Okay. Can we start the chest compressions for the V15/2, and push hard and pass allow good chest recoil. And Miss Fadi, can you take care of the airway? Give every 2 breaths, every 15 chest compressions. And can we analyze the rhythm? Stop for a while, analyze the rhythm. Okay, this is PEA, and continue the rhythm, continue the chest compressions, and I will assess the 4H and 4Ts. Yes, there is. Yeah, I am considered 4H and 4Ts. And for the oxygen, already hypoxia for the oxygen is ongoing, and hypertension fluids are ongoing. And for the hypoglycemia, hyperkalemia, any reports for the blood gases? Any results?
Normal.
Normal. And what about the temperature?
Temperature 37.
37. Okay. And can we give the adrenaline 10 microgram per kg according to the wet fly? And well, there is no chances of any thrombosis or in this stage, no history of trauma. And what about the toxins? Any pupils? What about the pupils?
Normal.
Normal. Any bottles or
Thank
any
you.
marks?
Thank you. Well done, Dr. Omar. What is your problem?
Here, the patient mostly hyperkalemia. No, the ECG
I did not say what is the problem of the patient. I said what is your problem.
Time management.
I mean, comment on yourself. What do you think?
Time management. I think you could not reach the end.
Yes, time management. Why? Why time
Yes,
management? You are not slow.
Because I think so going in too much depth.
You are not focusing on your targets. Okay, so for example here, the patient, what is the complaint of the patient?
Vomiting, that and vomiting.
Vomiting. You are expecting the patient airway will be patent or not?
No, not patent.
Because of
secretions in the mouth.
Secretion or vomiting? Did they mention
Vomiting.
secretion?
No, vomiting.
The patient, he has vomiting. I did not mention he has secretions. Okay.
Yes.
So here they are giving you 1 minute to prepare yourself for what? 10 seconds to check the pie chart. I found here resuscitation, team leadership, clinical reasoning, knowledge. So no teaching, no history. Okay. So after that, assess and manage the patient. It confirms its resuscitation. After that, 10 months. So 10 months here, APLS or ATLS or LS or newborn.
APLS.
APLS.
Yes.
Okay. So what is the station? Vomiting, diarrhea. Vomited diarrhea, you are expecting airway not beating, and also you can expect electrolyte imbalance. I was planning to do hypokalemia for you, but I will waste more time for you. Okay, you are wasting your time. I will waste your time more. No. Okay. Okay. So here, the patient be targeted to your approach. So ask the examiner, is the patient, what is the AFBO score for the patient responding to pain? Okay, so respond to pain here. If I said not responding, any signs of life, don't ask about look, listen, and feel and check the pulse. Okay, we updated this one, right? So
yes,
yeah, any signs of life? Okay, he will say yes. So what about the airway? Patent? He will say no. Ask him clearly. Any vomiting, he will understand that you are professional. Okay, if you will ask him any tongue swelling, is it logic?
No, doctor.
Did they mention he was eating? Okay, no. So ask about questions related or relevant to the scenario. One question, any vomiting? He will say yes. Suction. What about airway now? Bating. Done. High flow oxygen. Clear? Don't waste the time.
Yes.
After that, expose the chest, connect all monitors. We said, please, 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 guys. Number 1, oxygen saturation. Number 2, RR. Please, please, please. It will give you clear idea from the beginning. Okay? So once I will say the oxygen saturation is normal, it means everything, inshallah, will be normal in breathing. Clear, Dr. Omar? Okay.
Yes, doctor.
Okay, after that, see circulation, you did very well. Here, the patient not responding. What is the first action if the patient is not responding?
Signs of life.
Yeah, signs of life. No signs of life. What is the next action?
To start chest compressions by C.
5 risk breath. 5 risk
breath.
breath. So
yes.
this is a big mistake. A big mistake in the exam. Okay.
Yes,
I consider it a fatal mistake. Okay. So 5 risky breaths. Why? Maybe after 5 risky breaths, the patient will get signs of life, right?
Yes.
No need for CPR. That's why I say fatal mistake. Okay. So
yes.
I will go back. You ask in C in circulation. What about monitor, right?
Yes.
What is the heart rate?
77.
Is it normal for his age?
Ready.
Yes, no.
So in any station for resuscitation, please, please, guys, you have 1 minute. 1 minute you are checking your colleagues right and left. You are checking them. No. Here 1 minute, ask yourself, 10 months. 10 months here, infant or child?
Infant.
Infant. So I don't care. Please, guys, if you have children beside you, make mute your mic. Please, please, please. Okay. So here regarding 10 months, I don't care 10 months, 9 months, 7 months. I care is it infant or child, according to bradyarrhythmia guidelines, resuscitation guidelines. All guidelines I posted in the group. Okay. So here regarding infant, regarding bradycardia, if less than 80 or less than 60. So if infant should be more than 80. Okay, so this patient, Brady, okay, 77 Brady. We are talking now about bradyarrhythmia in pediatric. If child should be more than 60. So this ECG, if the age more than 12 months, will be normal. But because his age is 10 months, it's abnormal. Okay. Also tachycardia. An infant should be less than 220. If child should be less than 180. Okay. So bradycardia or tachycardia, if the patient is stable, so it's not arrhythmia. If the patient is decompensated, it means it's arrhythmia, whatever brady or tachy. So please go back, guys, to the algorithm. Okay, so what is the first action, guys, here?
5 rescue breaths.
5 rescue breaths. Okay, so patient with bradyarrhythmia, yeah, he has signs of life, yes, but he has bradyarrhythmia and his blood pressure is low and the CRT is high, so shock. So the patient has decompensated bradyarrhythmia according to the algorithm. Okay, I want you to start first action. First action according to the guidelines, they said optimize oxygenation. It means you will give 5 rescue breaths, back valve mask. Okay. After that, check the heart rate. So after 5 rescue breaths, check the monitor. If you find the monitor normal, you can proceed. If you find the monitor same or low, you have what is the next action, guys? After optimizing oxygenation?
Compression.
Check if there is excessive vagal tone to give atropine.
Yes. Check, consider if the patient has a reason of vagal tone or vagal reason. So is the patient intubated? That's why he has bradycardia? No, we did not intubate the patient. Okay. So check the patient unconscious. If the patient is unconscious and not responding to 5 rescue breaths, so what is the next action?
Chest compression.
CPR. Okay. CPR. Okay.
But here, Dr. Hani, the CPR will be also for 2 minutes and check, like 15 compression to 2 ventilation and check after 2 minutes again, like the usual in the cardiac arrest, or how the CPR runs in
CPR.
symptomatic.
CPR is CPR. CPR
Okay.
is CPR. They said the definition of CPR, cardiopulmonary resuscitation. They did not say CPR for 30 seconds or 1 minute. They said CPR. It means you have to follow 2 minutes CPR, okay? And after that, you can check if the patient is responding or not. Maybe after CPR, the heart rate will be increased, right? If heart rate increased,
yes.
So no need for further cycle. Clear?
Yes, clear.
Yeah, and also, Dr. Omar, what is wasting your time? I will consider for each and 40. What is the most likely cause here, reversible cause? Electrolyte imbalance, excellent. So you have to ask the examiner clearly. The most likely cause is electrolyte imbalance because of vomiting, or you can talk to your team. Guys, the most likely cause here, he has vomiting diarrhea. So what about ABG? Yeah, hypokalemia. So I will give potassium chloride and the fluids. Okay. So 2 minutes passed. No need to waste time in 4H and 4Ts. Okay. If you will explain hypoxia, hypovolemia, and yeah, it's professional and ideal. But for the purpose of the exam, believe me, it will waste the time. Okay, just verbalize like that. I will consider 4H and 4Ts. If you want to mention them by name. Hypoxia, hypovolemia, hypokalemia, hypothermia, and tension, pneumothorax, thrombosis, and by name quickly. Okay, but it will waste the time also. The most important, focus on the most likely cause. Okay, clear, Dr. Omar?
Yes.
Yeah. So if you will mention them in details or you will concise them, the same mark for this point. But at least you will reach reassessment, at least you will reach handover. Clear, Dr. Omar?
Yes, yes.
Yeah.
Yes, doctor.
Yeah. So in any station, how to mention everything in concise way, how to mention everything in complete approach. Okay. Dr. Muhammad Al-Karim?
Dr. Hani has a question here, please.
Yeah.
Okay, if the patient is already intubated and I give him atropine, do I need to wait for action of atropine, or I will proceed for CPR?
In practice, you have to wait for action. The interval between atropine and atropine 5 minutes. But for the purpose of the exam, you will wait for 5 minutes? No.
No.
Okay. So once you give atropine, just check the monitor and verbalize to your team. What about heart rate now? Heart rate by name, heart rate. Okay. Is the heart rate increased? If the heart rate increased more than 80, clear?
Okay. Okay.
Yeah.
Clear.
If a child, if the heart rate increased more than 60, by name, show the examiner that you are professional. Okay?
Okay, thank you.
Yeah, welcome. Okay. So,
Dr. Hani, sorry, where can I find the algorithms that you shared in which channel exactly? The latest algorithms, because I'm having difficulties accessing them.
Okay, I will share again. I will share all algorithms again.
Okay, in this active practice channel.
Yeah, inshallah. I will share again. It's there, but I will share again. No worries. Some people, they don't have the ability to reach everything easily. That's why sometimes I'm sharing the file more than one time. Okay.
Thank you.
Welcome. Next one, guys, please. We want to save time.
Yes, doctor.
Dr. Al-Karim. Okay.
Yes.
You can start.
Okay. Good evening. I'm Dr. Muhammad Al-Qalam, ED Registrar. May I know your name and level, please?
Yeah, I am Nadia. I am junior nurse.
Nice to meet you, Nadia. Are you ALS provider?
Yeah.
Okay. And can you handle airway?
Yeah.
Okay, and I need another patient for circulation because today, in a while, we are expecting one patient, 60 years old, male, with choking in a restaurant, and he's coming by the ambulance. His blood pressure low, and we will handle it right now. So let's wear PPE and wash our hand and wear PPE and call the resuscitation team just in case. And we need to go and check with the patient. Patient arrived?
Yeah, patient arrived.
Any endorsement from the ambulance crew?
Yeah, he was eating at the restaurant and suddenly he collapsed. He has difficult in breathing.
Okay. Hello, sir.
The patient is not talking.
Okay. I will look, listen, and feel. There is pulse?
Yeah, sir.
Okay. Let's check airway. Is the airway patent?
Not patent.
Not patent. Okay. Okay. Let's open the head tilt and chin. Let's open anything in the airway. Any foreign body?
No.
Okay. Any secretion?
No.
Okay. Let's try to do. Patient is unresponsive.
No, he is responding.
Okay. Let's do the back blow. Okay, let's do abdomen thrust now.
Doctor, can you check the pie chart?
Okay, so patient. Okay. So we are so any swelling in the tongue or the lips?
Yeah, the tongue is large and the lip is swollen.
Okay, so most probably he has anaphylaxis. So we'll give him now adrenaline 1/1000.5 milligram in the intramuscular anterior lateral thigh immediately. Given?
Okay.
Okay, so airway patent now?
No, the airway is not patent.
Okay, we'll give another adrenaline 1/1000.
How long between the first adrenaline and second adrenaline, doctor?
We'll give 5 minutes between.
5 minutes not passed.
Okay. So 5 minutes past now?
No.
Okay, let's give high flow oxygen. Okay, still airway patent?
No, not patent.
Not. 5 minutes past?
No.
So still airway is not patent, and let's try to intubate the patient. I am competent to intubate?
No.
Okay. We'll insert airway adjunct, oropharyngeal airway. Can he tolerate?
You cannot insert. He has large tongue. You cannot insert oropharyngeal airway.
Okay, we'll insert nasopharyngeal airway.
Okay.
Okay. And we'll put in high flow oxygen. How much oxygen saturation now?
Oxygen saturation now is 95.
95. Okay. Airway is patent?
After nasopharyngeal airway, you patent, yeah.
Okay. I'm happy with airway. Let's go for breathing. Oxygen saturation is 95. We'll expose the chest, trachea, central, and neck veins patent or not?
Neck veins? Normal.
Neck veins, normal. And trachea, central?
Yeah, central.
Okay, how about inspection, palpation, percussion of the chest?
One by one, doctor. What do you want?
Inspection?
Inspection normal. Inspection normal.
Okay, palpation?
Palpation, expansion normal.
Okay, how about percussion, 6 points?
Resonant.
Okay, auscultation of the chest?
There's diffuse wheezes.
Okay, we'll apply a nebulizer for him, Ventolin, 5 milligram. Okay, now how about respiratory rate?
Respiratory rate now it's 45.
Okay, I'm happy with breathing. Let's go for circulation. How about blood pressure and CRT?
Blood pressure now is 70/40.
And for CRT?
CRT now is 8.
Okay, so patient in shock. Let's insert 2 large bore cannula and give IV normal saline. Let's extract blood for biochemistry, blood gas.
Thank you, doctor. Thank you.
Thank you.
Okay. So here, what is the problem, Dr. Al-Karim?
I was dealing as a shock patient, shocking.
You mean foreign body?
Foreign body, yes.
Okay, one question. Any foreign body? No. Any large tongue or lips? Yes. So it's anaphylaxis. Clear?
Yes.
If he said yes, there is a foreign body. Any large tongue or lips? No. So the station is foreign body aspiration, right?
Yeah.
Very easy. Okay. So what else? I appreciate. I like Dr. Al-Karim. This happen in the real exam. They will ask you, doctor, can you check the pie chart again? I like when you correct yourself, and this will be good mark for you. Did you understand?
Yeah.
If the examiner show you the pie chart again, he tried to help you. He want to put you on the right track because he is instructed to do that. Okay, so if you do that, good for you. Okay, so here, why you want to give adrenaline again? Adrenaline, first adrenaline in primary survey or secondary survey?
Primary. The start primary.
Primary survey. And what is the second dose? Second dose after 5 minutes, right?
Yeah.
It means it's secondary survey, right?
Yeah, but the airway it was not patent, he told me.
Yes, yes, no worries. Do you think once you give adrenaline now, the swelling will improve within 1 second? Okay, so
yeah.
Here you can manage the airway without adrenaline, right?
Yeah.
As you did. So expect the large tongue. So you can involve your team. Guys, he has large tongue, large swelling, so no need to put oropharyngeal airway. Can you please put nasopharyngeal airway? What about airway now? You put high flow oxygen without asking me about patency, right?
Yeah.
You have to ask me first. Okay. After NBA, patent, yeah. So high flow oxygen. Okay. After that, exposed chest, connect to all monitor. What about oxygen saturation? RR, trachea, neck veins, inspection, palpation, percussion, auscultation. So don't ask them together. I'm telling you because I want to save time now. Okay. So inspection normal, palpation normal, percussion resonant normal, and auscultation diffuse wheezes. So regarding nebulization, first primary survey or secondary survey, guys?
Primary.
What do you think, guys?
Nebulization?
Yes.
Nebulization, secondary survey.
Secondary survey. Secondary survey. So no need to give nebulization here. Until the patient take 2 doses of adrenaline and no response. So it's called refractory anaphylaxis. Clear, Dr. Al-Karim?
Yes, doctor.
Yeah.
Clear.
So please check the algorithm of anaphylaxis and check attachment. Please, guys, if you have children beside you, make mute to the mic. Please be cooperative. Thank you. So if the patient not responding to 2 doses of adrenaline, so it's called refractory anaphylaxis. It means you have to give an adrenaline infusion, Dr. Al-Karim. So the next action, he when stabilized the patient, you already stabilized the patient. After that, reassess the patient, airway, breathing, circulation, disability, and exposure. You find the airway the same problem. Okay, clear, Dr. Al-Karim?
Yeah.
Yeah. You finished the airway, you finished the breathing, you finished circulation, you finished the disability, you finished exposure. I want to hand over the patient to ICU team. And in the meanwhile, I want to reassess the patient. What about the airway? Same, large tongue, large lips. So you will give second dose or not?
I will give. Yeah.
Did you understand?
Yes, yes, doctor.
Not in the meanwhile. Okay. So after that, what if the patient has airway patent from the start and he has wheezes? Okay, if the airway is patent, will you give adrenaline from the start? I'm asking you direct question from the start. You find the airway is patent, will you give adrenaline? No, no need. Until now, no diagnosis. The diagnosis of anaphylaxis is acute sudden onset of airway compromise or breathing or circulation compromise or skin changes. So if you find any of them and the sudden onset, the patient was eating 10 minutes ago. After that, he has large tongue and lips. So it's anaphylaxis. I will give adrenaline now, IM. I found the airway is patent. Will I give adrenaline?
No.
No, until now, not diagnosed. I will go for breathing. I found wheezes. So can I diagnose anaphylaxis now?
Yes.
Yeah, I will give adrenaline now.
Yes, I'll give.
Clear?
Yes.
Yes.
Yeah, I found airway patent. I found breathing normal and the circulation hypotension. Can I diagnose anaphylaxis?
Yes.
Can I give adrenaline now and see? I am?
Yes.
Yeah. So
Yes.
once you diagnose anaphylaxis, go for adrenaline IM. Okay. If you diagnose anaphylaxis in airway, number 1, adrenaline. In the meanwhile, you can manage the airway. If you diagnose anaphylaxis in B, give adrenaline. If you diagnose anaphylaxis in C, give adrenaline. If you diagnose anaphylaxis in E, exposure, skin changes in exposure, you will give adrenaline or not? Okay, so yeah, so reassessment, you will see, for example, airway patent and the B, there is wheezes. What will you do, Dr. Al-Karim?
Airway patent and there is wheezes.
Yes, what will you do?
At that time, I'll give adrenaline. At this point,
you have to inform your team the patient was eating in restaurant and he has wheezes, so it means anaphylaxis. Please give adrenaline IM anterolateral part of the thigh, 0.5 milligram. Okay, don't give nebulization. Okay, nebulization if the patient has refractory anaphylaxis and still wheezes. Clear?
Clear.
Okay, yeah. After that, you will go for C, you will go for D, you will go for E. After that, I will reassess the patient. What about the airway patent? What about the B? Any wheezes by name? Any wheezes? No. Will you give another dose of adrenaline?
No.
No need, because improved. Okay. What about B? Still wheezes. Will you give another dose?
Yes, we'll give.
Very clear now, guys?
Yes.
Yeah.
Yes, sir.
Okay. So the first dose in primary survey, the second dose, when you reassess the patient, if you find the same problem, whatever may be the same problem in the first time, only large tongue. In the second time, you find tongue is improved, but there is wheezes. You have to give adrenaline second dose because you find one of the criteria of anaphylaxis in reassessment. Clear, guys? Yeah.
Yes.
Clear.
Yeah. Okay, I wish. So maybe in the exam, they will let you to give 2 doses. Once you give 2 doses, so you will reassess the patient again. What about airway? Still large tongue. So you have to verbalize the patient has refractory anaphylaxis. I will give IV infusion for adrenaline. Okay, guys? Do you remember the dose? IV infusion? IV infusion? Refractory anaphylaxis?
No, no doubt.
1 ml per kg.
Okay, so you can review, guys. And here, if the patient has airway compromise, what is the action here? Nebulize the what?
Nebulize adrenaline.
Okay, if the patient has wheezes after 2 doses of adrenaline and refractory anaphylaxis, you will give nebulized what?
Salbutamol.
Okay, so what I need from you, review the PDF for anaphylaxis, refractory anaphylaxis. Okay. Okay. Next one.
Dr. Hani, one question. In the algorithm guideline 2021, UK, it's saying that the doses should be given IM only, but we can give it in experienced specialties. We can give IV as well. So if the patient having severe anaphylaxis from the beginning, can we give IV?
No, this you can give IM. Expert here, no need to put yourself in controversy. Okay, for the purpose of the exam, no need to mention IV at the start. Okay, just IM first dose, second dose IM. And if the patient is not responding, it means the same problem again. It means you have to give infusion. Okay.
Yeah, still infusion is also IV. So the patient is in resuscitation and under the care of the emergency medicine. So
Yes, no
it
problem.
is.
No problem. In the refractory, it will be logic.
Okay.
But from the start to start IV, it's not logic. Okay.
Okay, Dr. Hani, thank you.
Yeah, welcome. I'm talking for the purpose of the exam. Okay, next one, please, guys. We are wasting time. Dr. Muhammad Saadi.
Yes, doctor.
I was preparing to do many algorithms for Dr. Al-Qurain, but he did not give me chance to give him VF and VT. Okay. Okay. You have 30 seconds. You can start.
Yes. Hello, good evening. I am Dr. Mohammed Razaul, and I am ED physician. May I know your name and level, please?
Yeah, I am Nadia, junior nurse.
Yes, nice to meet you, Ms. Nadia. We received a call. We are going to be receiving one pregnant mother who just delivered. Mother and child are coming to the AR. So can you please call another staff nurse for assist us and call the neonatal ICU team and OB-GYN team. By the time you can prepare the wet flag, and can you able to manage the pediatric airway? It is
okay.
Are you competent with? So please arrange the airway trolley, and when the other stuff will be arranged, come please arrange the circulation and pediatric neonatal trolley. It's okay.
Okay.
And please inform the neonatal team and gynae team. Is child arrived? Child arrived. Will go and any handover?
Yeah, the patient was born in the other room.
Okay. Any normal delivery or any assisted delivery or
full term?
Full term. Okay, so for the mother taking her care, we'll take a handover for the child. Please cover the child. Start the stopwatch and make dry the child with dry towel and clean the child and remove the wet towel, cover with another dry towel, and if child will see the child is crying, if there will make suction of the oropharynx and nasal. If child will after suction, if there is any signs of life of child.
Yeah, there's signs of life.
Okay, we can give 5 rescue breath. Keep child in neutral position on the head and keep 5 rescue breath.
Why you want to give 5 rescue breaths, doctor? I'm the examiner.
To make the airway clear. Child is not crying. So Now child is crying.
No.
Okay. We'll make the head in neutral position. We'll make open the airway and give another 5 rescue breath. If saturation and maintaining.
Okay, Dr. Sadi.
Yes.
Okay, we will start from the beginning, but I have to give you IDA first. Okay, so here I will give you IDA, and after that you will do the same station. Okay, so please listen to me and follow me. Okay.
Okay.
Yeah. So this station is newborn or ABLS?
Newborn.
Okay. Full term or preterm?
Full term.
How you know?
I asked you told
Written
full
here.
term baby.
I'm talking about the scenario now.
Oh. Just
We don't know.
we don't know this full term or preterm because here nothing written.
Okay, be concise, please. So we don't know. 2 words more than enough.
Yes.
Okay. So here regarding this station newborn. So once you start, may I know your name and grade, please? Blah 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 blah. And you are you newborn provider, resuscitation provider? So always ask about provider guy. Certified, it means they have certificate only. Maybe they are not trained. Sometimes people they take certification without training. Okay. Are you trained? Maybe trained, but they don't have certificate. But provider, it means trained and certified. It means qualified and certified. So I like provider. That's why in the certificates you will mention ALS provider. Okay. Anyway, so are you newborn resuscitation provider? Yeah. And you? Yeah. Are you happy to manage airway? Yeah. Can you prepare airway equipment for newborn? And you? Can you manage circulation? Yeah. Can you prepare circulation equipment for newborn? Okay. Clear, Dr. Sadi?
Yes.
Yeah.
Yes.
We are expecting newborn in the other room. Okay. So please call which team?
Neonatal ICU.
Neonatology and the obstetrician team.
Neonatal.
Okay. Okay. So
Yes.
patient, we will wear PPE. We will wash our hands and wear PPE. Okay. Patient arrived.
Yeah.
Okay. What will you do?
On the stopwatch timer, number 1.
Assess. Okay. So here from the start in preparation, you will ask them to prepare what?
Prepare
Clock.
neonatal
Clock.
trolley.
Clock. Finish
Clock.
airway
Two dry
equipment. You
towel.
ask them for airway equipment and you ask them for circulation equipment. I am talking about what is special preparation. What is the difference between you and the other candidates? So please prepare clock. Number 2, resuscitate. Okay. Number 3.
Yes. Yes.
Number 3, 2 towels. Okay. What else?
2 towel. Yes. Umbilical cord clamp.
Okay. So here already you ask them for preparation. Once the patient arrives, what will you do?
We'll cover the child with cloth.
Start the clock.
Dry towel.
Start the clock.
Start the clock.
Okay.
Yes.
So you ask for handover. Is the patient full term or preterm, right?
Yes.
Okay. After that, start the clock. Number 2, turn on the air condition to be warm, right?
Right.
Dry the baby. Remove the towel. Cover by another towel. Clear?
Towel. Clear.
Until now, I did not assess the patient. Until now, I did not do resuscitation. So, number 1 in resuscitation, what? Assessment. So, assessment here, it means A, B, C, D, E, right?
Yes.
A here, it means airway, right?
Airway.
We are asking about Apgar score now. A, it means airway. What about airway?
Airway.
Patent? He will say no. Okay. What about B, breathing? He will say patient is not no chest chest is not moving. What about C? What about heart rate? He will say 40 or maybe he will say 50. He will give you reading less than how much?
Less than normal.
Less than how much?
80, less than 80.
100.
Less than how
80.
much?
Less than 80.
Less than 1.
60. 60.
Less than 1.
60, guys.
60.
60, please. We are talking about newborn. We are talking about newborn, not ABLS. Okay. So please, here, what about airway? What about breathing? What about circulation? So don't say circulation. What about heart rate? He will say anything less than 60. What about D, disability? Disability, it means?
Hani, just a question, Dr. Hani. If the heart rate is 70 in a newborn, this is considered normal? No problem. He doesn't need the
Newborn different than ABLS. Newborn different than ABLS. Okay.
Okay, Doctor.
Don't mix. Don't confuse. Okay. Answer me, guys. A, airway. B, breathing. He will say chest is not moving. C, circulation. You can ask about heart rate. D, disability. You will ask about muscle tone. Muscle tone. Okay. And color. Okay. So you will ask in C about heart rate and the color. You will ask in D about muscle tone. Clear, guys? So here the difference between newborn and all resuscitation, you can ask about all together. What is called Apgar score. Clear, Dr. Sadi?
Yes, yes.
Yeah. So you will introduce yourself to the team, ask them for preparation regarding the clock, the heater, the turn the air condition on warm, and also prepare 2 towels and resuscitator. And once the patient arrive, we did not start resuscitation, just dry with 1 towel, throw, cover by the other towel. Now I will ask about A, B, C, D. Okay. What about airway? Not patent. What about breathing? Any chest movement? No. What about C? Any? What about heart rate? 60, 40. What about color? Pale. What about muscle to floppy? So this patient need resuscitation or not?
Need resuscitation.
Clear? You will inform the examiner or your team? Okay.
Team.
So we will start resuscitation. So please, what you will do in airway, Dr. Sadi?
We'll open airway in neutral position,
Why
give
you
5
will waste the
rescue breaths.
time? Why you will waste the time? Suction.
Suction.
Why I will say open the head tilt, chin lift, open airway, and suction, done. You are in OSCE, you don't have time. Okay. If you will mention suction, done. For the examiner, done. Okay. This is how to save time. Okay. Suction. This patient just born now. Do you think he has foreign body from his mother?
No.
Do you think he has anything else? No. Just a secretion. Once you will do suction, ask the examiner. What about airway now? Patent. Done. We will go for breathing. Is the chest moving? You ask the examiner before and he said not moving. And you ask him again, yes, because you did suction. Maybe after suction, the airway is patent. After that, he can breathe, right?
Yes.
So after you do suction, what about airway? Patent. What about chest moving? No. So you will do back valve mask. Risk 5 risk breath. Okay. So, inflation breath. Okay. 5 inflation breath.
Yes.
So you have two back valve mask here in this one, as we said in previous recording. So inflation, how many seconds?
1
Inflation
second.
will be
3 seconds.
5 seconds.
Each over 3 seconds.
3 seconds.
It's not good, guys. We have previous recording and you don't remember. And you know that we will practice today resuscitation. You have to be ready for everything. Okay. So here, inflation, it means you will inflate the lung. Inflate, it will take time. It means you will inflate the balloon 2 to 3 seconds. Okay. Okay, guys. Later in C, you will do ventilation. So inflation in breathing. Ventilation where?
Circulation.
Circulation. So inflation in breathing and ventilation in circulation. Okay. So you will do inflation 2 times. Each inflation, it will be 5 times. Okay. So 1-person technique and the 2-person technique. So what about airway? Not patent. Okay, clear airway. What about airway now? Patent. What about chest? Moving? No. So please do 5 inflation breath, 1-person technique. Okay. Each inflation 2 to 3 seconds for 5 times. 1, 2, 3. 1, 2, 3. 1, 2, 3. Okay. Even if you will do that, believe me, you still have more time. Okay. So what about chest moving? Not moving. We will repeat the same and the head in neutral position. Just mention in neutral position. If you want to say, I will put under bed, under the neck to be in neutral position, it's okay. And it will be 2-person technique. Each inflation, 2 to 3 seconds. Is the chest moving? Now is moving. Okay. So after that, you ask about C, circulation. What about heart rate? Still 40. So what is the next action for heart rate, guys?
Ventilation.
Ventilation. So for breathing, you will do inflation. For circulation, you will do ventilation. Ventilation, it means breathe. 1 second. Okay. But inflation, you have to inflate. Like inflate balloon. Okay. It will take time. 2 to 3 seconds. Okay. So you will do ventilation for how long?
30 seconds.
30 seconds. Any intervention regarding C in newborn, 30 seconds. Okay. In ABLS, how long?
2 minutes.
In
2 minutes.
In ALS,
2 minutes.
2 minutes.
in newborn,
30 seconds.
30 seconds. So ventilation, 30 seconds. Not improving. Heart rate still. What is the next action?
CVR.
Chest compression.
Chest
Chest
compression.
compression. For how long?
30 seconds.
Not improving. Still heart rate the same.
Umbilical cord catheter. Adrenaline.
So CPR with medicines. CPR with medicines. Through access, right? Okay. So what is the intervention for airway?
Suction.
Suction. What is the intervention for breathing?
5 inflation.
5 inflation breath, 1-person technique. If not improving, 2-person technique, right?
Yes.
What is the intervention in circulation?
3:1.
Ventilation first.
Ventilation, 30 seconds. Not responding. CPR without medication. Not responding. CPR with medication, right?
Yes.
I think it's clear now. Who want to do? Are you happy to do this, Dr. Sadi, or other one?
Will do, doctor.
Again?
Yes, I will do, doctor.
Okay, you can start.
Hello, good evening. I am Dr. Muhammad Sadi, AD physician. May I know your name and level, please?
Yeah, I'm Nadia, junior nurse.
Nice to meet you, Nadia. Are you a newborn resuscitator provider?
Yeah, sure.
We need another one staff for circulation. We are getting newborn just delivered in the next room. They are arriving. So, are you happy to manage the airway?
Yeah.
Please prepare the airway trolley, and sister, can you arrange the circulation trolley and prepare the newborn resuscitator trolley. We are wear PPE and wash our hand. And please inform the neonatology ICU team and OB-GYN team. Child arrive?
Yeah.
Yes, please start the stopwatch. Any handover?
Yeah, the patient delivered now.
Station delivered. Is child is term or preterm?
Full term.
Full term. Okay. Please dry the baby. Cover the baby with dry towel. Remove the wet towel and cover with another dry towel. And put in the resuscitator trolley. And what about the airway?
Not beaten.
Sister, can you make suction or pharyngeal suction? What about the airway?
Beaten to now.
Beaten. And what about the chest rise?
Not moving.
Not moving. Sister, can you give 5 inflation breath? And every breath for 5 seconds. And what about the chest rise?
Not moving.
Can you make the head in neutral position? Give another 5 rescue breath. What about the chest rise?
1-person technique or 2-person technique?
Now 2-person technique.
Okay, it's just is moving now.
Chest is moving. Okay, good. Just we'll go for the assess the patient color.
Pale.
Pale. Continue with oxygen. And what about the patient tone, muscle tone?
There's floppy.
Floppy. The heart rate?
Heart rate now is 40.
Heart rate 40. So it's still give now 5 ventilation breath.
5 or 30?
Whatever. So 30 ventilation breath.
Okay, for 30 seconds. Okay.
For 30 seconds. So after ventilation, 30 ventilation, what about the heart rate?
Same, 40.
Please give another ventilation, 30 ventilation breath for 30 seconds. Heart rate in now how much?
Same.
So please, can you give CPR for heart rate still low? So 3 chest compression with 1 ventilation, and for 15 compression. Whatever the heart rate now.
What is the rate, doctor? This newborn, what is the rate?
Newborn, it will be more than 120.
The ratio, what is the ratio?
Ratio 15:1 ventilation. 15 compression is to 1 ventilation.
You mean 3:1?
3:1.
Okay.
3 chest compression and 1 ventilation.
Okay.
So after that, heart rate, how much now?
Still the same. 40.
So can we arrange adrenaline medication through the umbilical cord?
Okay.
We can, after adrenaline, the heart rate now how much?
Now, after adrenaline, what is the dose?
0.1 milligram per kg regarding the weight flag.
Should be 20 microgram. In newborn, 20 microgram.
20 microgram. So heart rate improve.
Yeah, now
adrenaline.
heart rate 100 now.
Okay, good. We heart rate achieve. We can
Thank you, doctor.
keep
Thank
maybe
you, Dr. Sadi. Thank you. Okay, time done. Okay, please work on the algorithm. Okay, and listen to this video. If you want to pass, you have to listen to this video more than 3 times. Okay, so please, guys, if you really want to pass, it's not about approach. It's not about PDF. The tricks in the videos. Okay, so here, be familiar with all guidelines. Newborn different than ABLS. Some people, they think newborn the same as ABLS. It's different. Okay. The most important here, don't do ventilation more than 1 time. The algorithm ventilation, it's 1 time. 30 ventilation for 30 seconds. Okay. After that, CPR without medicine. After that, CPR with medicine. The ratio 3:1. It's a fatal mistake in front of the examiner if you will say the ratio 15:2. Clear, Dr. Sadi?
Yes, exactly.
Yeah, okay. So please, guys, check the video 1 time, 2 times, 3 times. The people who passed with high score not better than you. Why you are lazy? You are searching for PDF. Why? Are you happy if you will go for the exam 1 time, 2 times, 3 times, 4 times? It's not good. People who passed with high score, they are listening to the videos 1 time, 2 times, 3 times, 4 times. You have list of people who passed with high score. You can contact them. What is the problem? You can ask them, what did you do? They will say, we listen to videos more than 2 or 3 or 4 times. What is the problem if the video 1 hour, 2 hours, 3 hours, 4 hours, even 5 hours? What is the problem? You can listen for 1 video even for 4 days. What is the problem? Okay, but you will get benefits. Okay, so don't be lazy.
Okay.
If you want to pass with high score, believe me, you will get high score if you will do that. Okay, thank you, Dr. Sad.
Thank you.
I will do this station. Anyone want to be actor for me?
I want to do it, Dr. Hani.
Okay, do.
Actually, I want to do it.
Okay, Doctor, it's up to you. Dr. Al-Amin or Dr. Abu Yahya?
Okay.
I can do it. I don't have a problem.
Dr. Hani,
Yeah.
I think you can carry on with the scenario. Neonatal is the new one. I guess it's better to start with you.
Okay. Okay, so Dr. Abu Yahya, because he did not practice today.
Yeah, ready?
Okay, you have 6 minutes. You can start.
Okay. Handover from paramedics. Is the child born here, please?
Yeah, the child is just born now and he is full term.
How about the mother?
Now she's with the obstetric team.
Okay. I have 2 staff with me or 1 staff?
1 staff with you.
Can you please put the call for neonatal team and anesthesia team, please? And please start the clock and let's put the baby on the 2 towels we already prepared. We need to stimulate and we need to dry the baby with one towel and then remove it and cover the child with the other towel to keep the child warm and expose the case, please. Is that okay?
Okay.
I'm looking at the child. I'm looking at, I want to see the color of, I want to know the color of the child, the muscle tone, and the breathing and the heart rate.
Yeah, the patient is pale and the heart rate is 40 and he's floppy and his airway is not big.
Oh, this child is critical. He needs to be resuscitated. Can you please, if you got a chance to apply cardiac monitor and SATS prop, please. I need to open the airway. Is there anything in the airway? Is there any
Secretion. Secretion.
Need to do suctioning. How is the airway now?
Better.
Okay, that's good. Is there any chest rising?
Not moving.
Okay, I need to give a 5 inflation breath. Each one is in 2 to 3 seconds, please. Is it done?
Yeah.
Okay. Is there any chest movement while you were doing that?
No.
Okay, let's do a 2-person technique, please. One is holding the mask and the other is squeezing the back. And let's put the child in neutral position, just to optimize the position. That's okay. And let's repeat the 5 inflation breath again. Every breath in 2 to 3 seconds. And let's make sure the chest is rising.
Now is moving.
Chest is rising, that's good. And now I'll move into circulation. How is the heart rate now?
The heart rate is 40.
Okay, 40. This is bradycardia and in neonate less than 60, we consider it as a cardiac arrest. Let's give a ventilation over 30 seconds, please. And let's make sure that the chest is rising while you're doing ventilation.
Yeah, the chest is moving with each ventilation.
Okay.
And the 30 seconds passed.
Okay. How is the heart rate now?
40.
40. So we still haven't reached the optimal heart rate for this child. Let's start now the chest compression at a rate of 3 to 1, please, for 30 seconds, and let me know.
I don't know how to do, doctor.
Okay, so and I only have one staff nurse with me. So if you are not competent, then I will do that. And it's either 2 hands in circling technique because we are 2 persons. And you can be on the giving the breath. Is that okay?
Yeah.
Okay. 3 to 1 and 30 seconds. When 30 seconds is passed, please let me know.
30 seconds passed.
Okay. How is the heart rate now?
40.
It's still 40. Now we have to go for medication. Let's get an umbilical access, and let's give 20 microgram per kg adrenaline, please. One intense hour.
How much is the adrenaline, please?
20 mic per kg.
Okay, done.
Okay, and let's continue. We are continuing the chest compression 3 to 1.
Okay.
Okay, and every 30 seconds, please let me know.
30 seconds pass.
Okay. How about the breathing? How about the heart rate?
What about
now?
the access?
Yeah, did we get the umbilical access?
Okay.
If not, we go straight away for IO.
Okay.
Do we have the access?
Yeah.
Okay. And while we are doing that, while we give an adrenaline and we continue in chest compression, I need the BM for the child, please.
They are on way.
Not the blood sugar.
Blood sugar now is 1 millimole.
1. So we need to give 10% dextrose, 2.5 mil per kg, please.
Okay.
And continue chest compression every 30 seconds. Let me know to reassess the child.
30 seconds pass.
How is the heart rate?
It's 100.
Okay, excellent. We keep thrusting this baby. Let's reassess A, B, C, D, E. Let's return to airway. How is the airway?
Beaten.
Okay, let's put non-rebreathal mask and start high flow of oxygen, 15 liter per minute. And is the mask fogging?
The chest is moving now.
The mask is fogging?
Yeah.
Okay, happy about the airway. Let's move on to breathing. You already connected the SATs prop. Can you let me know about the saturation?
Thank you, Dr. Abi. You can continue for 30 seconds.
Okay. How about the
98.
Sorry?
98.
Okay, it's happy about that. How about the respiratory rate?
It's now 20.
I'll listen to the chest. How is the chest? Inspection, palpation, auscultation.
All normal. All normal.
Good. Happy about that. Let's move on to circulation. You already have an axis, umbilical axis. And how about the respiratory pulse rate? You said 100. And how about it now?
Yeah, same.
Good. How is the capillary refill? Central. Can you press on the sternum, please, for 5 seconds?
Okay, so I am the examiner. What are the differential diagnoses?
So in this child was born term. I don't know about the mother. I will put on top of the diagnosis. It could be a neonatal sepsis because he was hypoglycemic.
In newborn resuscitation, not in this patient. What are the differential diagnoses?
Usually it's hypoxia causing the cardiac arrest. That's why we concerning about optimizing the breathing, optimizing the airway, and giving inflation, pressure, and ventilation. And the second cause could be the mother had morphine or opioid and caused the child to be drowsy. This is the second one, and the third one, it could be an infection.
Okay, thank you, Dr. Abu Yahya. Okay, well done. I have only small comments. You forgot to introduce yourself. It's a very, very important point in any station. You have to mention, I am Dr. Abu Yahya. I am the
Because you said we started with 6 minutes, so I said, let's move on.
Okay, so don't forget that, please. It's a big mistake. So you have to introduce yourself, because if I am one of the members, I will not accept you without introducing yourself. And you have to emphasize on, I am the team leader today, okay? And you have to confirm the ID and the level, okay? Are you a newborn resuscitation provider, okay? And also you will prepare your things. So please prepare blah, 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 blah. Okay.
I just because you said to start from the 6 minutes. So
yeah, 6 minutes, believe me, more than enough. I want you also to accelerate your tone.
There is one thing I need to add from the practice. We have a neonatal resuscitation. So we have a kit for resuscitating a newborn, and it have a CPAP, same as is mentioned in the algorithm. So we don't need to give ventilation through the back valve mask. We give it through CPAP. So can we use that on the examination, on the exam, or we just stick to the back valve mask and same as before?
Back valve mask more than enough, but if the patient is, you can consider. They said also in the algorithm you can consider intubation, but it doesn't mean you will do intubation. For the purpose of the exam, you will not need that. They want to test your skills. You will do 2 times inflation, and in circulation you will do ventilation for 30 seconds. And also for the safety of patient, you are calling team. So you called already for a neonatology team, but you did not call for other nurses to help you, and this is not good. You have to support the resuscitation process, okay? So if you will call for team, you are safe doctor. If you will call for other nurse, you are safe doctor. Why they will mention you have only 1 nurse? Because you are testing your skills, you will be safe doctor or not. I think it's a clear, Dr. Abu. Okay, so if you will call cardiothoracic surgeon, because you are safe doctor. If you will call for other nurse, you are safe doctor. So You are the team leader. Be free for giving orders. Okay. One nurse for airway, one nurse for circulation. And here, if she said, I don't know how to do chest compression, it will be a good communication skills. No worries. I will teach you how to do. So put fingers, 4 fingers in the back and the 2 thumbs in the sternum, and do 3 compression with 1 ventilation from the airway. Okay, is that clear for you? Yeah. Can you do that? Yeah. So it will be teaching, but concise teaching. Clear, Dr. Abuha?
Yes.
Yeah. It's if they said that, it means they are testing your skills in teaching also. Some people, they found, doctor, I don't know how to insert IO axis. Okay, I will teach you how to do that. We will insert here in the lower part of the end of tibia, anterolateral aspect. So is that clear for you? Yeah, done. Okay, concise. Okay, so you did very well. Everything is amazing. And here, regarding ABG, you have to check for ABG also. Maybe the patient has metabolic acidosis or severe metabolic acidosis. Okay, they said the likely causes here, guys. What? 3 important points for H and for T's. What is the 3 points?
Thorax, congenital anomaly.
Okay.
Bulimia.
Okay.
Cardiac anomaly.
Pneumothorax.
Okay. So you have to mention that, Dr. Abu Yahya, also. So here, this CBR or not CBR?
It is.
It is. Okay. So 2 persons here, one for airway, one for circulation. They will change or not?
Meaning, I didn't understand the question.
Is it any CBR, the one for airway and the one for circulation, they will change or not? Switch or not?
They should switch.
Yes. Switch. Excellent. So please start CBR for 3 compression and 1 ventilation from the airway. For how long? 30 seconds. 30 seconds passed. What you will do? Stop. Switch. Do another. Check the heart rate. Stop. Switch. Check the heart rate. In ALS and ALS, what we will say, guys? Stop. Switch. Check what?
Analyze the rhythm.
Check the rhythm and pulse. Okay, I'm talking about ALS and ALS. Okay, so stop, 2 minutes pass. Stop, switch, check the rhythm and pulse. In newborn, what will say? Stop, switch, check the heart rate. Okay, heart rate less than 30. Sorry, less than 60. So continue CPR for further 30 seconds. 30 seconds pass. Stop, switch, check heart rate. Still less than 30. Stop, switch, check the heart rate. Okay. But anyway, for the purpose of the exam, it will be 1 time for ventilation, 1 time for CPR without medication, 1 time for CPR with medication. Okay. Clear, guys?
Honey, in unit, because it's 3 to 1, so it's not tiring, but for
yes, I know, not tiring, but for the purpose of the exam, you have to do that. Stop, switch, check the heart rate.
Just because in other we do it because we need an effective chest compression and every 2 minutes.
Yeah. But anyway, you have to switch also. Okay.
Oh.
Maybe.
Dr. Hani, one question.
Yeah.
The drugs should be considered, adrenaline should be considered every 2 minutes or every 30 seconds?
Every 30 seconds. According to the algorithm, ventilation for 30 seconds. Also CPR for 30 seconds.
The drugs, adrenaline, I'm asking.
Here the drugs, it will be, we will review, but I think within 30 seconds. We will review this point. What do you think, guys?
I think 2 minutes.
I think 2 minutes, I think so.
Can be given according to the PALS algorithm, I think so.
Here you are checking the heart rate, not pulse. Heart rate more than 60 or not, right? So if it will be if more than 30 seconds and the heart rate is okay, no need for further adrenaline.
Actually, adrenaline is same as in the other, every 3 to 5 minutes.
Yeah, it's every 4 minutes.
But the dose is different. 20 microgram.
Okay.
Yeah.
Okay.
So 30 seconds, but we repeat the dose after 3 to 5 minutes. So average is 4 minutes.
Yeah. The most important, you don't have time in the exam. They will give you one time 30 ventilation, one time for CPR without medication, one time for CPR with medication. And here, just verbalize in CPR, I will consider for H4T. The most likely in newborn, blah, 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 blah. You mentioned the 3 points. You will find in resuscitation guidelines. Okay, guys? Yeah. Next one, who want to practice?
I will try, Dr. Hani.
Okay,
Dr. Hani, can I do it, please?
Hello, Dr. Hani.
Yeah.
Yeah, you were trying to say something just now. Somebody interrupted you. You were trying to say that there's about 3 major differential diagnoses in newborns.
Yeah, we mentioned already.
The 4H and the 4Ts?
Yeah, you have in CPR, you can verbalize like that. I will consider 4H and 4Ts. The most likely cause or reversible cause in newborn, you can say hypovolemia, pneumothorax, and congenital anomalies.
Okay, thank you.
Yeah, you will find in the resuscitation algorithm. It will be down. Okay. Okay. Next one, Dr. Amir. After that, Dr. Shayma. I think the last station will be Dr. Shayma. You can start, Dr. Amir.
Hello, good morning. My name is Dr. Amir. I'm a AD physician. May I know your name and your levels, please?
Yeah, I am Fathi. I am AD registrar.
Oh, wow, fantastic. Nice to meet you, Dr. Fatih. Do we have any nurse with us?
Yeah.
Okay, nice to meet both of you. Are both of you are ALS providers?
Yeah.
Okay, Dr. Fatih, I would like you to please take over the airway. I want you to prepare all the airway equipment, including the advanced airway trolley. And Menadia, I will just like to request you to prepare all the circulation equipment, IV cannulas. We are expecting one patient, Mr. Sohail, 60-year-old, who is coming in with drug overdose. So please activate the ALS team and wash your hand, wear the PPE. Okay, is the patient arrived?
Yeah, patient arrived.
Any handover?
Yeah, this patient, he has a history of heart disease, and they took medicine. They said it's overdose, but I'm not sure exactly. We
Thank you very
inserted IV access in both arms.
Thank you very much. Okay, I will just approach the patient. Hello, sir. Hello, sir. Is the patient responding?
Responding, but not talking.
Okay, I will. Is the airway open? Is the airway patent?
Patent.
Okay, Dr. Fatih, I would like you to please attach to the non-ribbing mask 15-liter oxygen and check for the misting. Is the mask is misting?
Yeah.
Okay, please expose the chest, attach, connect all the monitors, and please tell me the SpO2 and RR of the patient.
Yeah, SpO2 now is 98 and RR is 30.
Okay, is the trachea central?
Central.
What about the neck veins?
Neck veins are normal.
Any bruises on the chest?
No. No trauma.
What about no trauma? Okay. What about the chest movement? Bilateral equal?
Yeah.
Percussion, 6-point percussion normal?
Normal.
What about the auscultation?
Normal.
Okay, I'm happy with the B. I'll move to C. Sister Nadia, please, can you insert a new cannula and extract the blood for the hematology, biochemistry, toxicology, blood gases, also for the, blood cultures. And please, what is the heart rate?
Heart rate now is this one.
Okay. What about the pulse?
Doctor, we find here in his pocket tablet something like verapamil.
Okay, so guys, it is looks like case of overdose of verapamil. Can you check the pulse, Dr. Fatih?
What is that, doctor? What is verapamil?
Verapamil is calcium channel blocker, and it will cause a severe bradycardia. Okay, Dr. Fatih, what is the pulse? Is there any central pulse?
Yeah.
Okay, so we will consider. What about the blood pressure of the patient?
80/40.
Okay, Sister Nadia, can you start normal saline, 500 ml through the IV line, and reassess the BP and update me after 15 minutes. Please, also I want you to give him the glucagon for this patient to reverse the effect of the verapamil. Glucagon given?
Yes.
Okay. Is there any response? Can we check the cardiac monitor? What is the rhythm now?
Yeah, this one.
Still the same. Okay. Is there a pulse?
What do you mean pulse? You mean central pulse or peripheral pulse?
Yeah, central pulse. I mean, we have to check the carotid pulse for this patient.
Yeah, he has from the start.
Okay. Still he's bradycardic. So the patient is responsive and bradycardia algorithms. So I got stuck.
Yeah, what is this is bradyarrhythmia, right?
Bradyarrhythmias, yes, exactly,
So,
yes.
patient is stable or unstable?
Unstable. BP is low, so I will consider atropine, yes.
Okay.
Sister Nadia, can you just please push 0.5 mg atropine,
Given.
and we will check for the response. Given.
This is the monitor.
Okay, maximum up to 3 mg we will give, and
Given,
please
this is the
prepare
monitor.
for the please prepare for isoprenaline or isoprenaline infusion, and as a backup we will just need this one transcutaneous spacing. Please prepare it.
Okay, how to use that?
Okay, please attach the pads. The right side below the right sternum, the left side is below the left nipple, and please start the voltage with 30 milliampere and adjust the heart rate 60 and check for the response. Is there any gain?
Thank you. Okay.
Sorry.
Okay.
Will you give me 30 seconds?
Okay, I will give you 30 seconds.
Okay, please increase the voltage each time, 5 milliampere, and check for the response. Okay, up to maximum 60, we will increase. Okay, maximum given the voltage increase. Is there any capture? Electrical capture? No, no capture. Okay, increase the voltage again, please, and check for the response. Okay, excellent, guys. We have the electrical capture. Can we check for mechanical capture for the peripheral pulse and signs of blood pressure? What is the blood pressure
Blood
increase?
pressure is normal now.
Okay, excellent, guys. Please call I would like to hand over this patient to the cardiologist. Please call the CCU team. This patient needs transvenous spacing as a permanent resolve for the.
Okay, thank you, Dr. Ram. Thank you.
I very much.
Okay, so this patient already bradyarrhythmia. I don't care what is the reason behind that. You can still pass the station even you don't know about the antidote for calcium channel blocker, right?
Yes, Dr. Hani. I got mental block.
No, don't get mental block. Follow the general approach. Here, the patient has overdose, he is unstable or not?
Unstable, yeah. Since beginning it
Okay.
was unstable.
So anything related to the overdose, you can expect two problem in any overdose in practice or in the exam. Brain, heart, brain, heart. Okay. Brain means maybe CNS excitation or CNS depression. Excitation, it means the seizures. Depression, it means coma.
More, yeah.
Okay, depression, coma, excitation, seizure. Heart arrhythmia, maybe tachy or brady arrhythmia. Clear? So in any station, remember that. So be ready. Tell yourself, if the patient is unconscious, I will focus on the airway. Maybe the airway is not breathing. The breathing for sure may be normal or maybe brady apnea. Okay. The blood pressure here, if the tachyarrhythmia or bradyarrhythmia, the patient is unstable. So be ready for that. Tell yourself, you are in 1 minute preparation. How to use 1 minute preparation? Ask yourself, if tachyarrhythmia, what you will check, Dr. Amir?
For the pulse, I will check to decide synchronized or
The patient
unsynchronized.
already, he has hypotension. It means he has pulse. But I mean, if tachyarrhythmia, you will check for what? You will check if the patient has narrow or wide complex tachycardia, right?
Yes, boss.
Okay. So if narrow or wide complex tachycardia, and you will check the overdose. If TCA, you have a special consideration. If bradyarrhythmia, you will give atropine. So here you will give atropine because until now you don't know what is the reason, right?
Yep.
You will give atropine first, or you will ask them to prepare transcutaneous pacing first, or both of them in the meanwhile.
I will give atropine. I will tell them to prepare. We may need to.
Yes, please insert 2 IV access. If 2 IV access in place, so extract blood for hematology, biochemistry, blood gas, blood culture, toxicology screen, and give atropine 0.5 milligram. The maximum up to 3 milligram, 5 minutes interval. Okay. And in the meanwhile, turn on the pacing, connect the pads. No need to mention in details. You don't have time to mention this pads here, this pad here. No need. If they ask you clearly, where will you attach the pad? It means they will give you marks for this point. You have to answer properly. Okay. So,
okay.
Yeah, attach 2 pads, anterolateral. Okay. And you will start the pacing. Here, 70, the rate 70 by default. Once you will turn on the monitor, it will be 70. You will not do anything. Clear? 70
yes,
by default. In all monitors, it will be 70. Here, the milliampere, it will be 0 by default. Once you will turn on the monitor, you will find here 70, you will find here 0. You will start by 0 or you will start by 30?
30.
30. Don't waste time. You will start by 0 and then 5 and then 10 and then 15 and then 20. You will waste the time. But you will start by 30. After that, increase 10. Don't increase 5. Save time in the exam. 30, 40, 50, 60. Done. If you want to start by 40, no worries. Okay? So 40, 50, 60. Okay? He will show you this monitor. You can say, I can see pacing, but no electrical capture because no waves between pacing. This pacing and this pacing, there is no waves here. I can see waves here, but no waves here. No waves here. So it's pacing without electrical capture. I will increase up to 60. Okay? Now I can see pacing and the electrical capture. Why? Between 2 pacing, there is waves. So QRST. Okay? So here, if the patient is conscious, you have to give him sedation. If the patient is unconscious, no need for sedation. Clear? And don't waste time. Yeah. Here, once you find the bradyarrhythmia, we need to search for the reasons of that. Can you check his pocket? Any tablet? He will say verapamil. Okay, we will start bradyarrhythmia algorithm by atropine. In the meanwhile, prepare glucagon. Okay, so they said consider glucagon. What does it mean, consider glucagon in the algorithm? It means if not responding to
the pacing atropine,
excellent.
then we give.
They said in the algorithm down. They did not mention up. They put glucagon down. Down, it means down what? Down atropine, right? Okay.
Right.
Dr. Hani?
Yeah.
This patient has a calcium channel blocker overdose. Okay. So calcium channel, we will not give calcium here.
Yes, you will give calcium.
And there is a QT prolongation. What about the magnesium here?
Here, the most important, you have to follow bradyarrhythmia algorithm.
Okay. Okay.
Number one, bradyarrhythmia algorithm. You will give antidote for calcium channel blocker, calcium. Okay.
Okay.
Calcium chloride. And also, you can consider in beta blocker or calcium channel blocker, glucagon, right?
Glucagon. Okay. Thank you.
Yeah. But you have to follow the algorithm. Okay. So if you want to start by calcium direct and check the response, okay. But here, if you have clear station, so if they said we have verapamil from the start, so no worries, you can start by calcium from the start because it's a clear station. But sometimes they will show you verapamil in arrest. I was planning to do arrest for Dr. Amir, but he did not give me the chance. He's very slow. Okay. Anyway, we will get a chance later for practice for this station. No worries. We will practice
Dr.
more.
Hani, isoprenaline and adrenaline.
Yeah, it
should
will
be before.
after transcutaneous, sorry.
Okay.
Yeah. So the first line atropine, second line transcutaneous basing, third line adrenaline or isoprenaline. Adrenaline will be 2 to 10 microgram per minute. Isoprenaline 5 microgram per minute. Any of them, don't use both. Okay, don't waste the time. And if clear from the start, you can use calcium chloride. Okay.
Thank you, Dr. Hani.
Welcome. But they will show you in arrest. Dr. Shaima?
Yes, Dr. Hani.
Yeah. This is the last station, guys.
Just one addition, Hani, in especially in calcium channel blocker and beta blocker, if the patient did not respond and still the patient is hypertensive, you can give high dose of
insulin dextrose.
This is usually not the case. It's not, you can't find it any, it's not available anywhere, this information, but they like to ask about it in the exam.
Yeah. But here, I want all people to follow the general approach. I want you to follow the algorithm of the resuscitation council. They did not mention insulin dextrose, okay? But you can put an option, okay? So you can consider as option. Okay.
Yeah.
Dr. Shaima, you can start.
Shaima, the registrar, can I know your name and your level, please?
Yeah, I am Nadia. I'm junior nurse.
Nice to meet you, Nadia. You are alone. We need another nurse with us. Are you happy to manage airway?
Okay.
Can you please prepare for the airway equipment, and if we need the anesthesia, you can call them, please. And the other nurse, please, you are happy to deal with cardiac maneuvers. So please prepare for the medications, fluids, and please, if we need the trauma team, please call them. And there is any let us to wear the baby the baby and waiting for the patient. There is any endorsement from the EMS?
Yeah, this patient RTA and he has pelvic injury. It was crash engine.
Is there any line you put for him?
No.
Sorry for that. I will now do my middle line stabilization of the neck. Please, sister, my nurse, please, you are familiar to do the neck collar?
Yeah.
Yes, please, can you do it? Sir, are you okay? Are you okay? He is
The patient is not talking.
Yes, how is the airway?
Airway is patent.
Please, can you put non-rebreathing mask with high flow of oxygen is 15 liter, and let us to stabilize his neck with the neck collar. Is still the airway is clear?
The airway is patent, doctor, from the start.
Okay. Okay, thank you. Okay, we are happy for the airway. Please go to breathing. Let's expose the chest. How is the neck vein?
Neck veins are normal.
And the trachea?
Center.
And how is the saturation now? And the
98.
respiratory rate?
17.
Hello?
17.
Hello?
Yes, 17.
And how is the saturation now?
98.
98. And the respiratory rate? Okay. Please can you put the monitors and let us to see if there is any chest expansion? Yes. So there is any chest expansion? And how is the expansion of the chest? Is equal?
Yeah, equal.
As is the inspection, is there is any scars, bruising and bleeding sites?
Normal.
Okay. How is the percussion? The 6 points is good.
Resonant.
And auscultation?
Normal.
And the breath sound by 6 points is good.
Normal.
And how is the heart sound now?
Normal.
So are good for breathing. You are going to how is the heart rate now?
140.
Heart rate 40, and the blood pressure?
70/40.
So please, can you put a line and extract fluid, and please can you do it? Put the normal saline 1 liter warm normal saline, and please how is the pelvis now? Can we still abnormal? Can we fix it?
What do you need, doctor?
I need to fix the pelvis to if there is any bleeding or anything.
Okay, what do you need in examination in pelvis?
Is there any bruises?
Yes, we will find the bruises.
There is any bruises? There is the pelvic bone is moving.
What do you mean by moving? Stable?
It's fly hip.
Do you mean a stable pelvis?
Yes, I mean it's stable or not?
Yeah, stable. Not stable.
Yes, can we fix it?
How do you want to fix it?
Sorry for that.
Okay, you want to apply pelvic binder, you mean?
Fixed binder, yes.
Okay, thank you, Dr.
Fixed binder, yes.
Okay, thank you. Okay. Well done, Dr. Shaiman. Please, guys, you have the previous recordings. Listen to them, okay? If you will listen every day for one recording, you will finish everything, okay? So here, you will go for airway, breathing, circulation. If I said airway patent, no need to check the airway. If I said, you ask me, is the airway patent? Yes, patent. No need to say, what about secretion, vomiting, and. Already patent. So apply high flow oxygen. And here, exposure of the chest. Connect all monitors. Also prepare chest X-ray and pelvis X-ray. What about oxygen saturation, RR, trachea, neck veins, inspection, palpation, percussion, auscultation. After that, circulation. Circulation, ask about blood pressure, CRT, inspection, palpation. Okay. And after that, you can give, you can extract the blood first. Extract the blood before giving medicine. Okay. So extract for hematology, biochemistry, culture, toxicology screen, and give fluid. In the meanwhile, continue assessment. So inspection, palpation, and the pelvis. Is the pelvis stable? What about long bones? Okay, long bones, it means 4 limbs. Any deformity, any injuries? Normal. So you will apply pelvic binder. What about blood pressure? Is still low. So next step, you will give O negative blood. Next step, of course, you have to call the specialty early. Who is the specialty here, guys?
Vascular.
Orthopedic.
Orthopedic.
Trauma team.
Of course, a trauma team, but here orthopedic by name. Okay, so you will start by fluids, warm fluids, 1 liter, not responding blood pressure. You will start O negative blood, 2 units, still low blood pressure. You will give 4 units or 6 units cross match. Okay, not responding, tranexamic acid. And here, every time you can ask about the orthopedic team. Okay, still blood pressure is low and the orthopedic team not here. What will you do, guys?
Send to OR.
Yes, move to OR. Okay, anyway, guys, please listen to this video and listen to other videos. I was preparing, you know, now we are in the middle of stations. We did not discuss abdomen blunt. We did not discuss methadone, toxicology in pediatric, abdomen penetrating, flail chest with COPD, also major amputation, massive hemothorax, hypothermia, ALS, but you are not helping me. I was expecting you are doing everything professionally and I will give small feedback, but unfortunately you are not well prepared. Okay, so anyway, we will practice again and again later, don't worry. So we will stop here because of the time. Okay. Okay, anyone has any question before we start?
What about tomorrow, Dr. Hani? What will be the session and the time?
I will post in the group, inshallah. Thank you, guys. Thank you.
Thank
Bye.
you.
Bye. Bye.
Thank you. Thank you.
Thank you.
Thank you, Dr.